Please welcome to the stage Dr. Robert Margolis and Mark McClellan.
Thank you all for joining us today. Good afternoon. Buenas tardes. Bob, I'd like you to come up and make a few opening comments. Bob Margolis is the founding donor that established the Duke-Margolis Institute. Now, Bob, almost 10 years ago. Thank you for being here.
Thank you, Mark. Welcome, everybody. This annual conference becomes bigger, stronger, and more well attended, and it shows an enormous interest across our country in how are we going to make America healthy again is the latest acronym, something we all know needs to happen. And the Policy Institute is at the forefront of using academically ordained information through its research and trying to move that into health policy application. It's an exciting time, and among other things that the Institute does is a big, broad educational program. And one of the proudest things, I think, over the last 10 years is the interest in young people now in health policy. As an example, we had over 850 applicants for internships in the Health Policy Institute, could only take 12. And as a result, it's easier to get into Duke than it is to get into the Health Policy Institute, which I think is a true comment about the beauty of health policy. We have a very exciting agenda. I give my thanks to the leadership of the Institute, Mark and Jillian and the amazing staff. And thank you all for attending and paying close attention on how do we make America and American healthcare better for all of the patients. Thank you.
Great. Thank you, Bob. Just again, my thanks as well for you all being with us today, to all of you who are joining us here despite the weather in Washington, D.C., and all of you who are joining us online. More than 1,800 people have signed up to participate in this. This is our 4th annual Health Policy Conference. Each year, we try to focus on a range of challenges and the newest, most important opportunities to address them in health policy and health reform, working across the public and private sector, working across the aisle, with a focus on where there are the best opportunities for progress, where there are the best opportunities for making progress as often as required together. This is today a focus that includes if you look at the agenda, attention to what I think of as one of the most important agencies for America's health, especially in the parts of the population that can benefit most from innovative healthcare, and that's the Center for Medicare and Medicaid Services. We are very pleased to have the new leadership of the CMS spending time and effort here with us today, talking about some major announcements made just today on the pathway forward for innovation and achieving the goals, as Bob just mentioned in his opening comments, that I think we all share. It is pretty clear that our healthcare policies and our healthcare delivery systems are not where we'd like it to be and are changing. One thing that health policy is famous for is that it keeps adding acronyms. We've had 2 new ones added in 2025. One is MAHA, a renewed emphasis on addressing the risk factors, the chronic disease progression issues that account for so much of the burden of health and healthcare costs in the United States particularly. Another new acronym is DOGE, sort of shorthand for taking steps, bold steps, both in spending and in program or policy changes, including not just agency staffing, but issues like cross-country trade affecting medical products. We're going to cover a lot of these issues. We are going to hear, as I said, from CMS, as I like to say to my team when I had the privilege of being CMS administrator. This is the largest public health agency in the United States and the world, because how CMS pays, how it regulates, how it works with healthcare providers, all of its beneficiaries, and everyone in the United States matters so much. At CMS, Dr. Oz has brought in a range of experienced policy leaders. He's built teams with the career staff at the agency, including some very experienced career staff who actually start out with me and have come back to take on some of these challenges today. And they are engaged in translating these new policy directions, these new acronyms into health reform initiatives, including the initiatives just announced that we'll be hearing more about today. We're also going to be hearing from Democratic leaders at the state level, including Governor Wes Moore of Maryland, and also state health secretaries like Dev Sangbai from North Carolina, former Democratic federal executives, people who also share recognition that our healthcare institutions have not yet succeeded in addressing the challenges that many Americans are facing in their health. Again, particularly some of the under-resourced populations and working class Americans who have really been struggling in improving health in recent decades. And we will hear from a range of private sector perspectives on these reform steps to help guide and help inform what will be, I think you'll hear about today, public-private efforts to try to transform healthcare in America. And we're pleased to have such a range of perspectives together with us today. Last thing I want to say before getting going is that this conference would not be possible without the generous support of our sponsors for this event, the Alexandria Summit and Foundation, the Robertson Foundation, the Collective to Strengthen Pathways for Health Research, the Peterson Center on Healthcare, West Health, and USP. I'll hear more about from some of them later today as well. And again, it really is all of you working together with us. If you go to the website, there are opportunities to use a QR code to submit questions for those of you who are with us online. There's a QR code up on the screen here for questions or comments you'd like to make. We'll build those into the discussion. But right now, I'd like to get started by introducing the current leader of CMS, and I think the man of the moment in healthcare reform, one of the most popular speakers to get.
Much of what colored my life actually was playing sports in college, because I recognized playing at the collegiate level that if I didn't tune my body, if I didn't understand how to use it appropriately, I wasn't going to thrive, I wasn't going to succeed. So it was surprising to me when I entered medical school that we didn't have a class in nutrition. In fact, many of the things that I learned in the arena of sports wasn't discussed in medical school. And that's a big issue, because if you go through medical school and you don't learn about nutrition, as an example, then you don't think it's important, right? Because everything that's important, you need to know to be a doctor, you learn in medical school. So you immediately discount and devalue some of these preventive approaches, which over time is turned out to be a massive flaw in our system, because it has allowed the American population, for a variety of reasons, to get sicker and sicker. And so what I thought I would do is give you my perspective of where we are today, and then tease out some of the things we're going to be doing coming up. Much of it, however, is going to come out in the discussion that Mark has with an unbelievable human being, Abe Sutton, who runs CMMI, one of the people that I was most aggressively recruiting as soon as I learned I was going to be offered the position, because you need top people in top positions to succeed, and you'll see why I'm so high on Abe Sutton in a few minutes. So let's first start off with where I work. The Humphreys building, which is right next to the Capitol. I see the Capitol outside my window. Is an interesting building. It was built in the brutalist movement. Now, brutalist is a weird name for an architectural movement, but it quite aptly describes the building, which is not very pretty on the outside, but miracles are happening on the inside. The part of this job that Mark did not warn me about was how smart the people are in the job. People around me, I've got about 6,500 people that I'm blessed to work with. We have 40,000 contractors we work with. These are smart people who know a lot about the technical the application of law to the well-being and the healthcare services of the American people. But there are challenges that happen along the way. And the biggest one, I think, sometimes happens when you don't pay attention to the fundamentals. So as you enter into the Humphreys building, the Health and Human Services building, where Secretary Kennedy, myself, Jay Bhattacharya, FDA, and maybe a lot of groups spend time there. There's a quote in the wall that says it's the moral test of government to take care of those in the dawn of their life, the children, to take care of those at the twilight of their life, the seniors, and to take care of those in the shadows, the underserved, the vulnerable, the folks who are struggling at any part of their life. And so if you truly respect that, and every great country does protect their most vulnerable, and we're great people, so we'll do that, you appreciate that some challenges that are not going away. So the question is, how do we deal with these challenges in a way that actually allows us to thrive as a society? Now, as a physician, it's my obligation to give people bad news sometimes, even if they don't want to hear it, because long-term, I think it's in your best interest. And so I think there are a couple headwinds that you should be aware of. And some of these are ones that are self-evident, but you may not appreciate how critical they are right now in our history. Number one happens to be the number one, which is the right way of describing the Medicaid budget in most states. If it's not the number one budget item, it's the number one fastest growing budget item. And we've been approached at CMS by governors, both Republicans and Democrats, who are aligned on one fundamental reality, that Medicaid growth is crowding out other services that they feel obliged to provide some support for in their role as chief executive of the state. Medicaid leaders in the states, which obviously are on the hot pan right now dealing with these issues, also feel like sometimes their hands are tied. They can't do the innovative things they want. And yet much of what we've tried to do in innovation hasn't resulted in taking that cost curve back to a place where it could rest. And there are many reasons for this, which I'll get into. I use the number 2 to remind myself that we increase our healthcare budget at about 2% faster than the U.S. economy is growing. And over time, that has resulted in the U.S. Health economy being twice as large per capita as any other developed nation on the planet. So it is hard to argue that we need to put more money into the system, especially when number 3 reminds me that number 3 cause of death in America are healthcare errors. So 1, 2, 3, you've got the 3 sort of high-level bullet points. The biggest healthcare item in the states, we're growing 2% faster than the economy. We're already twice as large as the end of the healthcare system. And despite that, the quality of care is not that great. In fact, if you want to go to number 4, when I was in medical school with Mark and many others in this room, the opportunity for us in Europe seemed the same. Our life expectancies were similar. But right now, we're about 4 years shorter than the Europeans in life expectancy, and we're falling further behind. Now, much of that is because we've got more chronic disease in America. We're at 43% obesity, not overweight, but true obesity is 43%. The number in Europe is about 20%, half of us. The number in Japan is 5%, about 1/10 of us. So not surprisingly, if you don't have a chronic illness driven by obesity, which drives about 70% of the U.S. healthcare budget, then you're going to be in a much better place when you're trying to keep up with the needs on your healthcare system. So what are you going to do about it? Let me paint you a picture of what the world might look like even a year and a half from now. And there's an RFI, which will come out while I'm speaking, I hope, which is a request for information by CMS to learn more about what each of you think about a health IT modernization in America. What is actually possible? And so there's a lot of moving parts to this, but it's very achievable. Imagine a year from now that the average beneficiary of Medicare, and remember, we have 68 million beneficiaries now, but we're going to have 90 million beneficiaries within a decade. And that's not counting all the other reasons the prices might increase for Medicaid. Just that alone, demographic requirements are going to force us to take charge of some of these cost issues. But if you think about an average beneficiary opening their phone and getting a couple specific bits of advice, tips for the day. It could be lifestyle based. It could be they're not taking their medications. It could be that they've got this pain they haven't addressed that they need to see a doctor for. But if they decide they want to do something about whatever their issue is, it's going to help them find the right doctor or remind them which doctor to go to. It'll give them ideas about costs. When they go see the doctor and the plan gets evolved, it'll allow them more insights into what the pharmaceutical impact might be. Remember, 1/3 of patients don't even fill their prescriptions because they can't afford to. So it doesn't really help us to give you better quality advice if you're not able to act on that advice. You'll also be given data on the cost of an x-ray you might need or a follow-up therapy that's seemingly important, but you should know what it's going to cost you. So that's about empowering people, getting our biggest ally, the most important stakeholder, someone who's completely aligned with the well-being of America because they want to stay healthy so they can be a participant in our society. So their sweat equity will be harvested and they'll be able to play a role. Then you have the providers who today are unfortunately a forgotten part of the equation. Often they're employed, 75% of the time, they're employed by a hospital, private equity, or a large insurance company. They often feel like they don't truly have autonomy over their practice. They're completely engulfed by paperwork. Many physicians claim they spend as much time filling out documentation as taking care of the patients. And it's very, very destructive to that precious covenant, the doctor-patient relationship, if the doctor's over here typing away while you're trying to tell them something vitally important to your well-being. So much of that will be addressed as well, because we'll be able to collect real-time data while you're taking care of the patient. Nurses, MPs, PAs, everyone will be in the same place in terms of their workflow. While you're gathering data real time, much of that data will be vitally important to telling us how sick the patient is, how risky the procedure is, all the kinds of things that will allow a more accurate and precise billing for the services offered. The information could be collected, shared with the patient, shared with their family. You'd have doctors getting decision support, which will allow them to maybe make better decisions. We already know that AI-driven tools are better at passing board examinations than doctors. It might be that they're better in some disease categories. I'll give you an example. Most doctors did not go to medical school, nor NPs to nursing school, to tell the same story about what diabetes can do to your body to every patient they see all day long. So what if some of that work was done by an avatar that could actually communicate with the patient in a way to make me better, more patient than a clinician? And then the clinician comes in towards the end of the discussion, the last 25 minutes or 10 minutes of the discussion, whatever's required, and actually connects on the real issue by looking the patient in the eye and making sure that these stories are sticking. That is a emblematic opportunity for us, because if we can get that to work, then now all of a sudden the shortage of workforce, which is affecting this country, especially in our rural areas, becomes less of a concern. We'll have enough behavioral health experts. We'll have enough general practitioners to start to provide some of these solutions. Now, while we're doing all this, right, we got the patients empowered, we got the clinicians and the providers incentivized, we're doing quality control, we're figuring out who should get paid what where. As this process evolves, technology will continue to improve, which will allow us to improve, as long as we get some of the fundamentals done correctly. And that's what this RFI that's coming out seeks to discern, collecting data from people like you. But what the message it's really sending is that we're open for business. And that's one of the reasons I came here today. If you're in the private sector or in the public sector looking at private sector solutions, recognize that we want to have a lot of good ideas percolating to the top, ideas that government could maybe try to do, but I actually believe it's better for the private sector to solve this. If government is building the racetrack and putting the guardrails and making sure the turf is safe for the horses and the sod's well placed, and you've got a set of rules that make it easier to understand who's going to win and who's going to lose, then let private sector solutions reign. Let the stallions, the jockeys, the different elements of the ecosystem that have to thrive come around and start conducting the best as they can the race for success in the healthcare space. And I believe that message is going to be loudly heard because people like you are able to take it and decipher it and translate it to people who trust you in your judgment. That's why this conference is so important. And so if we do all these things correctly, there's going to be some derivative benefits. For example, fraud, waste, and abuse. At CMS, we have a war room now that has been weaponized with IT. We can go through and scrub data very carefully. There's about 1 trillion different efforts to attack CMS a week. And the reason for that is we're a massive target, right? We're almost $2 trillion if you include the monies that we direct Treasury to give out for the ACA, almost $2 trillion of annual budget. It's a wonderful place to go hunting for fraud, waste, and abuse opportunities. And so people do that. And we have uncovered massive amounts of fraud for that reason. I'll give you a couple examples, and these are pretty well vetted examples. We believe there's about $1 billion a month that is lost because beneficiaries are registered in more than one state for Medicaid, or they're within Medicaid and the Affordable Care Act in the same state. So those two categories, being doubly enrolled in multiple insurance plans, because you're not paying for them anyway. So you're not really auditing your insurance. You're just given Medicaid, you're given the ACA, or you're in Medicaid in New Jersey and Pennsylvania. Now all of a sudden you got $14 billion, we think, annually, more than $1 billion a month of money lost on that. There's smaller amounts of money that are lost for subsidies for things that we don't think belong in regular Medicaid. These are subsidies for public unions and childcare issues around that, subsidies for student loans, subsidies for a variety of other programs that if we wish to do it as a country, we should decide to do it. We have some states allowing Medicaid for illegal immigrants, though that's not the rule of the nation. That means, for example, specifically, citizens in Florida are paying extra federal taxes in order to cover illegal immigrants getting Medicaid in California. So that's not really fair. Either we should all do it or none of us do it. But if the law is none of us do it, which is the law, then you can't have some states doing it and some not. And there's opportunities, we believe, to course correct on that. And that's just in the Medicaid side. If you talk about things like drug spend, there's a reason for the executive order yesterday catching so much support. Because most Americans agree that it doesn't really make sense for America to subsidize research and development of life-saving pharmaceutical advances and other devices as well. And yet 70% of the profits of these companies come from the American taxpayer or the American citizens. Even pharma executives agree that it's not quite right if the price differential between a drug sold in Europe and the United States is 2, 3, 4 times difference. So you're paying 3 to 4 times more for the exact same product in this country, and yet we ban you from importing it and going around the system because the system's not serving you. So there needed to be reckoning, and folks even within the industry agree there's an opportunity here, sort of like what happened with NATO, when we recognized that they're supposed to pay their 2%, their commitment to the group, and it turned out they weren't paying it, and we were picking up the tab. President Trump was able to negotiate effectively for European countries to pay their fair share. We believe that's what's going to happen with most favored nation status on drug pricing, to give the American taxpayer and the payers of healthcare systems in this country an equal footing. I can go on and on. There's many examples. We have an extraordinarily innovative group led by some really strong people. I think we got some, I don't know if they're in the room. Steph Carlton, is she in the back there? Put your hand up. Dressed in red, you can't miss her. She looks kind, but she's a killer. She didn't feed me for a week. I lost 4 pounds. I went on Ensure. I started taking supplements just to keep going. But we have others in the room that are peppered among you. I bring them up because these folks are superstars when it comes to delivering high quality care to the American people, and they're really, really tough folk in dealing with some of the adversities, the headwinds that we will often run into. I believe that at its very core, we have a generational opportunity to reform the healthcare system. And I say that not just because I've been blessed to be able to recruit people who believe it's the case. People like me, frankly, who would not have normally come into government, but we see an opportunity. But we also have a crisis, and you never want to waste a crisis. And we've gotten people to give up big time jobs outside of government to either return or come for the first time in the government and undertake the challenges that are required to address the structural collision course that we're on. But it will not work without your support. We don't need cheerleaders politically. We can deal with the crisis and the criticism that comes from the jobs we've taken. What we do need is your innovative ideas, and for you to keep pushing and shoving to make sure that the best ones get to the front. We're going to support companies who are doing the best thing for the American people, no matter where they are in the development cycle. I was asked during my Senate confirmation about my sentiments on private equity and outside moneyed interests coming into government. And I told the senator asking the question that I did not think it was possible to compete with the incumbents if you did not let money flow in to support the insurgents. So we don't want to restrict free flow of capital. We don't want to restrict the free market system from functioning as it does when it's healthy. But there are times when the free market system gets captured. And when we have crony capitalism, that's not good for healthcare either. And so I would argue that there probably is an opportunity for outside groups, insurgent groups, to compete more effectively with large companies. And there's a good thing that happens is when that occurs, which is the big companies do a better job. So hopefully they'll up their game as well, because this is no time for intellectuals, as we would say in the operating room. That literally was a line used by a colleague of mine when he had a patient that was hemorrhaging. And it was quite effective when I heard him say it. You know, in my time of need, I don't want to be surrounded by intellectuals. I want to be surrounded by people of action. You're all smart. I would ask you, plead with you, It's almost your patriotic duty at this point to put your best ideas forward and see what we can do to benefit the people that were described by Hubert Humphrey in that quote I started my discussions off with. If we do that effectively, you'll have great ideas. We'll support those great ideas, and we'll be able to continue to lead the healthcare revolution, the evolution that needs to happen in this country. So with that as a preamble, Abe Sutton is a remarkable individual. Has had experience in government, but in private equity as well. Incredibly insightful about the secondary and tertiary impacts of the things that he's going to innovate. So his job, if you don't know what CMMI is to come up with innovative models to check some of the big questions we have, to kick the tires on ideas to see if they really would work or not. But when you do this kind of work, and this is not just a small experiment in a little county, you can do nationwide experiments and huge investments. And this is a statutory codified desire by the federal government to do experiments on purpose on big questions to figure out if they work or not. But one thing I've learned at CMS, which becomes readily apparent with even a cursory review of the opportunities that happen in healthcare finance, is that when we put money into an idea, we shift the market. And sometimes there are untoward consequences from that. A good example, by the way, is the site of service debate that is currently raging. If you pay more for the same procedure to be done in a hospital than outside of a hospital, and there's reasons why you might want to do that, to support a rural hospital, for example, that has to stay open 24/7 and doesn't get reimbursed enough doing 1 EKG at 3 in the morning, so pay them more for the ones they do during the day. Makes sense. But when you do that, hospitals say to doctors, hey, listen, if you do the procedure, you'll make $10. If we do it, we make $100. Come work for us. We'll split the profits, right? Business. It happens. That's how doctors' practices get bought up by hospitals. So the untoward effect of decisions become quite apparent over time. So as we're steering the ship of CMS, we want to try to see past the first level interactions that are going to be caused and predict second and third degree changes. And Abe is an expert at that, which is why you'll throw out an idea which sounds great at a cocktail party and it'll tear it to shreds. And so you'll get to see that firsthand in a minute. God bless you all for being here. Thank you for being part of this conference. And I look forward to hearing all your good ideas. Take care.
All right. Well, Abe, after that, you definitely don't need an introduction, but nothing like high expectations when you're getting started. So not only is Abe in the midst of doing all of those things that Dr. Oz just talked about, he literally just before coming here announced the CMMI innovation strategy going forward. I mean, this is right before this event. Maybe you could start out by telling people a bit about, they've probably read it already. This is a group that has been following these issues very closely. Regards CMMI as a critical part of the future of healthcare innovation led by CMS. What are some of the key concepts that you took away from that in putting the plan together and getting it out today?
First off, thank you, Mark, and thank you to the whole Duke-Margolis Center for hosting this and organizing it. And thank you to Dr. Oz for that introduction. Very kind introduction. High expectations now. I won't rip anyone to shreds, but I do hope to have a conversation around our new strategy as a center, because it is grounded in the statute, which gives very clear expectations for the Innovation Center in what we should be doing. We should be focused on improving quality and on lowering the cost of care, very in line with both the call to make America healthy again and the call to focus on government efficiency in this moment. That's what the mandate of the Innovation Center is. And so in laying out this strategy, which is all designed to make America healthy again and land on a foundation of protecting the taxpayer, we aligned on 3 strategic pillars. The first of those pillars is about evidence-based prevention. There's a lot of different efforts in prevention, but if we could focus on ones where there's an evidence base and an appropriate evidence base for the type of intervention we want to do, we can gather information to see where a functional medicine intervention can make a difference, where we could go and do an intervention and that will matter for people's health. And so that is different in measurement and it's different in incentive structure, but we put a lot of thought around that as a center. We also are focused on empowering people to achieve their health goals. Much of this takes the form of new technology and tools for people. Dr. Oz mentioned that there's a new request for information that we put out from CMS today. A lot of that touches on tools for value-based care. How should we reimburse for new technology models, and how should we think about what payment models look like for that? That's something that we've been putting a lot of thought into. We also continued our commitment to accountable care and value-based care. There's updates there about aligned incentives, but it's all about patient empowerment and patient incentives and beneficiaries, which has not been as much of a focus to date for us. And our third pillar really builds on the important work that President Trump kicked off in his first term on choice and competition in healthcare markets. We speak about the independent practice of medicine a lot. And it's been hard as more and more of the healthcare market has been concentrated with a few players for doctors, for PAs and MPs to practice independently at the top of their license and have an impact. Just the structure is rigged around against them. If we look at site neutrality, as Dr. Oz mentioned, certificate of need, which protects incumbents. And so we're putting thought—
The administrative burdens of practice.
We're putting thought into making that working, to making our models be more predictable and less burdensome for participants.
Okay, that is quite a lot to follow up on, and I think a lot of opportunities for public input too. Just to start diving down into it, you emphasize the taxpayers as across all these three prongs, a goal of getting towards savings. As you and others have pointed out, there have been some challenges in at least documenting savings in many of the Innovation Center models to date. And I wonder if you could talk a little bit about what you've learned from that and how that's may unfold, or what you'd like to hear from people about trying to get to more clear savings. And I'd like to put a special emphasis on prevention as part of that. So that's going to be in every model. I saw that in today's release. We're going to hear from people today who have some frontline experience with trying to address non-medical factors like nutrition or other behavioral lifestyle issues that impact health. I have to say, most of what I've heard from him, Abe, suggests that it takes a bit of effort and funding up front to help support people in changing their lifestyle, to get those apps in place, things like that. The savings comes over time, but it does mean maybe some challenges in getting really short-term savings, at least from that piece alone. So how is savings really, do you think that's really going to unfold in the new CMMI?
It's a great question. The savings are obviously a critical part given the statutory mandate that we're entrusted with. We cannot operate a model that's not expected to produce savings. But there are a variety of different scenarios that the Office of the Actuary at CMS gives us that we base things on. We look now at the mid-case scenario as a center in looking at the expectations for what a model will achieve. And what that has allowed us to do is say we need to be in that mid-case scenario expected to be a savings. So the collective impact of a model needs to put us there, not that each individual aspect needs to put us there. So to talk about prevention and whether a functional medicine, lifestyle medicine, a nutritional change in intervention is likely to produce savings in and of its own right. Now, there might be some interventions where we see a sufficient evidence base to have confidence in that, in which case we could build something around that and have that as a core component of a model. But there are two other scenarios that I think of where I think we can act and collect data to establish the evidence base. The first is one where the participant in the model is making the choice to do an activity. And so what we do is use our waiver authority to allow them to do it, or use our authority to change beneficiary copays such that there's not a barrier to access. And we collect information on the delivery of that service and the impact that it has. But the entity at risk is actually the participant in our model who took on the risk. That requires a lower evidentiary standard for us at the Innovation Center to be comfortable allowing that service to be delivered. There's a mid-case scenario between those two as well, where maybe we're at risk and maybe we do not have the full evidence base to say this is something that will be likely to lead to savings, but we do it in the context of a model where there are other aspects built into the model that will produce savings. So maybe we're guiding people away from low-value care options, which are really expensive, high cost, maybe surgical interventions that are not right for people, and directing them more towards physical therapy. Can we, as part of that, pay for some of the other services that people wouldn't have otherwise gotten access to. If we expect the first part of the model to produce savings, we could have some of them pay for this part of the model.
One other, and there'd be a lot to follow up on there. Thank you for that answer. One other issue that Dr. Oz brought up, and for that matter, the president brought up this week, is drugs, drug pricing, drug payments. On the one hand, biomedical innovations, especially drugs that can help intervene early, prevent diseases from progressing. Going even further than that, you have a gene therapy model that is one of the ones that is continuing. That cures the progression or a lifetime chronic disease. That's a key part, I think, of this overall strategy. So can you say more about how you expect to take a new look at drugs, prevention-oriented biomedical innovations that seem to fit into the overall strategic model that you're developing?
Yeah, it's a great question. I think drugs, and I'll call out Medicare Advantage as well, are both spaces where the center needs to do more. If we're going to get at people's full cardiovascular health, we need to get at the root causes of diseases. In some cases, a lifestyle intervention is the appropriate way to do so. In some cases, more traditional medical interventions can get there, but there are also cases, like you highlighted, the cell and gene therapy model focused on sickle cell, where drugs get at the root causes of a condition, literally at a genetic level, and therefore position us to help people live healthier lives. And so that's the type of innovation that we want to encourage manufacturers to engage in. The president has obviously been very clear in his direction to help make sure American patients are put first and are getting a fair deal when accessing pharmaceutical products, all while encouraging the appropriate amount of innovation. And so we, at the Innovation Center and at CMS broadly, as you heard from Dr. Oz, obviously part of that solution in moving forward the president's agenda.
So 2 other questions, at least, that I'd like to get to in our limited time together. And thanks for being so concise in your answers. You can just leave out saying, "Oh, what a good question." I didn't think they heard that. But you have also
great questions.
I know.
I got to recognize it.
You have also, in this strategy, highlighted how critical value-based care is to achieving innovation centers, and Dr. Oz highlighted that as well. In the previous Trump administration, your predecessor actually helped set the goal of transitioning the entire healthcare system, starting with Medicare and Medicaid, to value-based payment, value-based care, away from fee-for-service. That's still the goal, and what are the new steps that, since it has been challenging to get there, any steps that you'd like to expand on right now that are going to help you do it?
Maybe I should have more anecdotes built in, right? That's the sense I'm getting. You know, when working with physicians in the companies that I helped start over the last few years, we dealt with physicians often who had not experienced value-based care before, and some who had more experience. Yeah. There was a difference in how they engaged. All were eager and all were interested, but there's a learning curve involved in value-based care. That's just how the system works. You're going from one style of medicine that maybe you've practiced for 30 years to something that's really different. And that's a hard transition to make. It's one that people are really eager to do, because once you make that transition, it's hard to go back. You see a change in how you engage with the patient. You see how you could spend time on the things that really matter for them. And that makes a difference, and it makes you feel, I think, more satisfied at the end of the day, was what they shared with me. In thinking through that, that's a goal that I think can never be abandoned. We have to help people engage with patients in ways that get at the root causes of disease, help them live healthier lives, and help them live fulfilling lives. It's important also to make sure we're designing models where there are active tools to engage them from a technology perspective and active incentives to do that engagement. We've found at the Innovation Center that when we have upside-only payment models, there's not necessarily an incentive systematically across the entire healthcare system for participants to change how they engage in care delivery. We found more impact for independent physicians engaging in our models. We found more impact for those with downside exposure in our models. And so I think the refinement I would make on that goal is that we want to move more providers to be in risk-based models with downside risk.
And especially providers who aren't necessarily part of big conglomerated healthcare systems, the rural providers, primary care practices, specialist groups, things like that.
Yeah, that's critically important. I mean, even from a competitive dynamic perspective, if you think about how Dr. Oz described site neutrality fueling acquisitions of physician practices by hospitals, and then I don't know, most cities, you don't have 15 hospitals that are major in it. There are some exceptions, but you have 2 or maybe 3 hospitals, or in some rural communities, 1 hospital. And then that hospital enters the negotiation with the payers in the market. And suddenly the incentive structures look very different than if there's a variety of different people all competing to serve patients, and therefore putting the patient's interests first to help them live healthier lives. And so I think getting to that market level competition is critical for us to actually be in a system where people are empowered.
Now, you've talked some about strategies around providers in alternative payment models. You also emphasized the beginning, and this is present in the strategy that you released today too, an increased emphasis on beneficiaries. And that's actually the main thing that Dr. Oz talked about. And also the importance of reforms that affect Medicare Advantage, maybe by extension, your other CMS programs, Medicaid. Can you talk a little bit more about what that shift means, what it might look like going forward?
Yeah, it's a great question. Much of what I've said to date is about the incentive for provider. But you picked up in the paper about how we speak a bit about the incentive for a participant, for a beneficiary. If you're just a person, when will you engage and when will you respond to outreach? Why is my doctor suddenly calling me up to say, hey, you should come in, we need to get you to do this. You missed a dialysis appointment, and why are they proactively engaging? And what's the incentive for me to proactively engage and think differently? Well, one incentive might be, hey, it's your health outcomes, but it's sometimes hard to translate that. It's sometimes hard to see how me doing this activity will result in me feeling better 2 months from now. And so making that information clear and translating it into incentives that people respond to. Maybe that takes the form of gift cards, maybe it takes the form of sharing in savings or credits towards your premium amounts for Part B. So we're thinking through incentives there, thinking around nudge theory and a lot of what gets sets up there.
What should Medicare Advantage plans be ready for?
So for Medicare Advantage plans, in many ways, they've been driving the innovation that we see. So you saw a structure where we were entrusted to do more innovation in original Medicare. The statute does allow our authority to extend into Medicare Advantage so that we could encourage testing of different type of structures as well. We obviously did that in one form with the VBID model. And VBID has seen many beneficiary incentives or supplements extended actually into the original Medicare, into the Medicare Advantage statutory program. Just over time, they've been adopted. I think we're thinking through what the next generation of that looks like and how we could give the right incentives for plans, particularly to encourage competition from regional blues and smaller players throughout the healthcare system.
And we talked about a main focus on Medicare, but you also highlighted in the release multi-payer approaches, ahead, working with states, building on those approaches. Can you say a few words about that?
Yeah, we remain committed to working with states on Medicaid programs. Ahead is a really creative model where we work with states to implement not just the Medicaid program, but also using their authority to impact the commercial market space. I know the governor of Maryland will be here later today.
Yes, he will.
And so Maryland's one of the states that has signed up for Ahead, and in many ways a successor of an earlier model that had many of the ingredients to lay the foundation for Ahead. So I think we're going to continue to operate the Ahead model and partner with states, and also look for other ways to partner with states on ways that our authority and their authority work together to drive system-wide change.
We're just about out of time. We could go on for a while, but there's some really interesting panels to follow. They're going to pick up on the technology issues that you've talked about, Medicaid, underserved population issues. But I'd want to ask about one thing you didn't announce today is any new models. We've been talking a lot, though, about improvements and changes in existing models, getting prevention into all of them, applying lessons to how to get more savings, maybe more participation, making it easier on providers. Are we going to see in the next round of the Innovation Center more of a focus now that we've got like shared savings program as a large part of traditional original Medicare, MA is a majority of Medicare? Are we going to focus more on steps that can be slotted into these existing programs, less on 5-year longer new models?
I wouldn't say that. I think there's still room for alternatives to some of the structures. And so I don't think MSSP needs to be the chassis for the entire ACO structure. I think there's room for things that go beyond what the statute allows MSSP to have. I think there's room for new models to operate in the Medicare Advantage space as well. And so I think there's room for more innovation and more payment models still in original Medicare, MA, and in drugs.
So with that in mind, more to come. And just to give you something to end on, other than the shredder comment, so what would you tell people here who want to contribute ideas to this effort about how to reach out? What are there some new ways or some other approaches to bring in that public-private collaboration that Dr. Oz talked about? And I assure him in the nicest way possible, your shredding approach.
We're really nice when you bring us ideas. We promise. We react positively. We smile. We engage. And we ask serious questions because we value people taking the time to give us input. And that's speaking for me. It's speaking for my entire team at the Innovation Center. The team at the Innovation Center is really some of the most innovative people in healthcare, period. People who have spent time in the private sector, people who have spent time at think tanks, people who have spent time at state government levels and have come together to say, we value the opportunity to design different ways of doing things and put them in action in an evidence-based manner. It's truly a privilege to spend day in, day out working with the team at CMMI, and I would invite you to come and engage with us. So on individual existing models, there's an email address on every one of those pages to say, engage with us, send us input. We would love to set up meetings. We'd love to talk. We'd love to hear from participants and stakeholders with ideas for models. For new model ideas responsive to the strategy and the vision that Dr. Oz, Secretary Kennedy, and President Trump have laid out, we welcome ideas. And so don't hesitate to do that. We'll be hosting a variety of listening sessions, but also please say hi today while we're here. Looking forward to hearing from everyone. Thank you for hosting this. I know there's a lot of panels to get to, but I do hope it's helpful for participants in our models and people with ideas for future models to hear about this, and look forward to future engagement.
Well, thanks for saying nice things about my questions. Thank you for some frank and concise answers, and thank you especially.
I actually have a critique for you of just I would shred the questions.
Well, thanks especially to you and the CMMI team for putting this all together as part of a CMS that clearly, it's a tight team, a tight budget, but really wants to engage. Looking forward to talking more about these issues today and onward. Abe, thanks for being with us today.
Thank you.
Thank you.
And we are doing a quick stage change here to bring up the panelist for the conversation on medically and socially underserved populations. While folks are coming on the stage, we'll note that we have 4 really distinguished people. Coming up, we have Stephanie Carlton from CMS, who will be joining here on my left. We have Dev Sangvi, who is the Secretary of Health and Human Services for North Carolina. We have Jana Eubank from Texas Community Health Center Association, and Toya Jahi from City Block Health. So please have a seat. And thank you all for coming. We could do much longer introductions and your very impressive bios, but I think we want to jump straight into content. And maybe, Stephanie, I'll start with you. We've been talking about a number of announcements here this morning, especially thinking about the Make America Healthy Again agenda. And given the goal of this particular session on medically and socially underserved populations, where do you see opportunities? What are the implications of that agenda for these types of populations?
Sure, and thanks for having us today. I think what we see translate down is a vision that was really set by Secretary Kennedy and the team that he put together. I came from Texas, and even a lot of my Democratic mom friends are like, I don't know about you Republicans, but RFK Jr. is cool. And because he's catalyzed a movement that is really about how do we take better care of ourselves, how do we take better care of our families, and really get at some of the root drivers of what is making America sick right now with chronic disease and prevention. And I think that that is not something that is limited to a specific income level or type of population. It is something that's important for every American, and that really does flow down to our most vulnerable population. So I think that's the first thing that I would say is the vision that was set and the team that was brought together to really advance that vision. And it flows through every part of what we're doing at CMS. You heard a bit about Abe's vision with CMMI and the things we're doing in innovation. So many of those programs and models have a chance to materially change health outcomes. And I think that's one thing that's probably the most important thing that all of us came to do, is to make some of the policy changes that really not just fix the system, but that change health outcomes so the systems works for the people we're here to serve. So I think that is really critical. And everything that we're doing. I'll give you another example outside of the Innovation Center. As we think about measuring quality, there's a lot of important tools that we have as an example in the Medicare Advantage program. But when you're a practitioner and you get measured on quality 18 months after you deliver care, something's wrong. And it's not just what we're measuring, it's how we're measuring it. And we're asking questions as a team on how do we really use technology and data to transform how we deliver care as it's delivered, and how do we set the right incentives so that caregivers can actually focus on health outcomes and they're rewarded for doing the right things for their patients. So that's something you heard from Abe. That's something we're really trying to infuse an ideology across everything that we're doing at CMS. And then I think thirdly, we've got literally we have a celebrity leading CMS. That's one of the most incredible messengers I think the Republicans have had on healthcare since I've been doing healthcare over the last 20 years. And you put all of those things together holistically, and it really cascades to every part of what we're doing. And at the end of the day, it is really focused on how do we improve health outcomes for the most vulnerable in our societies. I can get more specific later, but let me pass it on to.
Yeah, and maybe let's unpack a little bit here. So the title of the session is Medically and Socially Underserved Populations, but that includes a number of different types of people. And maybe let's talk a little bit about what groups are underneath that banner and what are the specific needs that those groups have, and what do we see as opportunities, things that have worked well in improving health for those different populations. And maybe Toyin, I might start with you and work our way this way.
Sure, I'm happy to. And again, it's such a privilege to be here. And the quote that you cited earlier, Dr. Oz, really gave me goosebumps because I think of my work and my career certainly as serving those folks who live in the shadows. And what that translates into, from my perspective, is thinking about different ways to understand and characterize those populations. We serve folks on Medicaid with medically complex needs, with a lot of significant behavioral health and social challenges, as well as folks who are dually eligible for Medicare and Medicaid, who are a relatively quite small proportion of the population, but represent a significant amount of spend in the healthcare system, which of course we have to address. But most importantly, on a human level, these are the folks who are most likely to fall through the cracks. And I think one of the things that, that to your question about what's worked, and actually that gives me a lot of hope and optimism from the agenda that you all have laid out today, is that the first thing that works is understanding that the population is not homogenous, that people have very different needs underneath the bucket of you are a Medicaid member or you are on Medicare. What sits underneath that is the complexity of their lived circumstances, their ability to access healthcare services, their social networks and relationships, their fluency and literacy around healthcare, all of the sort of undocumented traumas that they have experienced accessing healthcare. All of that stuff translates into someone who's going to have a harder time accessing the traditional healthcare system and getting better because of it. And so using data, using technology to help us actually understand who folks are, I think is really powerful. We've been talking about personalized care in the United States for a long time. And actually the first time I heard people talk about it, I thought it meant figuring out exactly what that grandmother living in a 5th floor walk up in the Bronx who has 5 chronic conditions and has nobody to make sure she has dinner every night gets in her healthcare system. What we really meant was like genomics. But we started to evolve to better understand that actually, your genome is only a tiny proportion of what actually dictates your outcomes. And if we can point the technology and tools and resources we have to better understanding exactly how we meet the needs of specific individuals who are likely to fall through the cracks, we can then deploy better care and interventions towards them. So that's one, is using data and understanding that there's a lot of different types of folks who sit underneath that bucket of our most vulnerable and underserved. And I think the second is then figuring out how to align incentives. And again, Abe talked about this, and I know the Innovation Center continues to think about this, but where most of our doctors are operating in a fee-for-service environment where they are not incentivized, and they just, even if they want to, they cannot figure out how to go find that person who didn't show up for their appointment today, who could be in the emergency room, could be asleep on a park bench somewhere, could be suffering an overdose, could be incarcerated. They have no idea where they are. They're not incentivized or reimbursed to go find them, build that relationship, and bring care to them. We've got to figure out how to reassess and realign incentives to deliver better care outcomes. I think if we can do those two things and then expand, as I think you all have done, and RFK Jr. has really pushed us to do, or expand our definition of what makes us healthy to include our environment, nutrition, the activities that we personally as individuals have control over, then we can actually do something here. And it's really amazing to hear all those threads coming together and to think about, that this is a chance and opportunity to have the biggest impact for the people who have the most to gain and the most to lose, frankly, from how broken our healthcare system is today.
Thank you, Joy. And Jana, would love to turn to you. I know you work with a number of community health centers across the state of Texas, and would love to see and hear what you are seeing in terms of population needs and what's working well that could be scaled more broadly.
What you said just really resonated with me. I do work with and represent federally qualified health centers in Texas. Obviously, a challenging state. We have very limited healthcare infrastructure. We have a lot of poverty. We have a lot of shortage of primary care access and preventative offerings for our communities. And I really loved what you had to say, Dr. Oz, about, our healthcare system is really well financed. We're spending $4.9 trillion a year in the United States on healthcare, but only 5% of that spend is on primary care. And if you look at Medicare, it's 3.4% on primary care, and on Medicaid, it's 4.3%. So I think we do need to reallocate and really start doubling down and focusing more on prevention and primary care, because that's it. And to be in the communities where our patients live is a huge part of the success of the community health center model in terms of our ability to really connect with them, get them to come in for care, or we go out to them for care, and have a very comprehensive model that not only includes medical, but also integrated behavioral health, dental health, which is huge. There's so much need in terms of oral health in our country, pharmacy. Increasingly, health centers are also providing vision care. And so we can make it very easy and accessible for our patients in medically underserved and vulnerable populations that we're taking care of. One of the things that Texas is doing that I think is a great example of really a federal and state partnership, we have serious access issues in Texas, particularly related to primary care. And so the state has invested in community health centers and has started an FQHC incubator program. They like our comprehensive model that also addresses social needs, which is so critical, particularly when you're talking about low-income Medicaid and Medicare recipients and marketplace recipients. But the state is investing in expanding access, particularly in rural and frontier communities where we have, You know, we have a lot of challenges in urban areas, but in rural Texas, and this is, I think, consistent across the country, there's really limited infrastructure. So we really need to start investing in primary care. We really need to start being more holistic in terms of how we approach care. And it does pay off. We have seen cost savings and better outcomes for doing that. And you build trust and rapport with the patient, because the patient is really the most important person in our care team. And that's the approach that you have to take.
Secretary Sangbai, I turn to you. You've been Secretary of Health and Human Services in North Carolina for a few months now, and North Carolina is a purple state with great geographic diversity. Would love to hear from your perspective what you're seeing as the greatest needs, and again, what do you see as working well that can be scaled?
Sure. Thank you, Robin. Let me first start by saying thank you for the opportunity to be here. I enjoyed a 23-year career at Duke before taking this job 4 months ago, and one of the greatest joys was to be affiliated with the Margolis Center. So Bob, thank you for your vision for putting something like this together. It may surprise you to know that North Carolina is the second most rural state in the country, second to Texas. And I had actually not learned the term frontier until I actually took this job. And there are parts of North Carolina that are indeed very frontier. And I think it highlights our biggest challenge, where some of the comments that were made with respect to technology, incentives, primary care are so important for our state. So I'm excited about how much is happening in CMS, and CMMI resonates with what the need in North Carolina is. Our rural areas are challenged the same way others are. I think the other thing that I found fascinating is that sometimes we tend to connect the dots in medicine in ways that are maybe non-connectable, but there are some that really do connect here. Our rural areas have very fragile rural hospitals. I'm sure the same is true throughout the country. So if those hospitals aren't able to do what they need to do, they end up challenging the local economy. There's more pressure put on those hospitals to service primary care through the emergency room and some of the other things that we've thought about. So our plan is to really think about how we stitch all of that together. And honestly, Medicaid is a big part of it. You know, Medicaid is a $30 billion economic engine in North Carolina. Medicaid allows, when we expanded Medicaid, we have started to fix our childcare challenge. I talk to childcare workers in our state, which is part of in the purview of my agency, and they say, I can't take this job, which pays 60% of what I can make at Costco or somewhere else, if Medicaid had not expanded. And so we've got this real challenge to figure out, how do we keep this elegant but very delicate balance moving forward?
And building on Abe Sutton's fireside chat, a number of topics that he raised are relevant for this panel. One of them is thinking about evidence-based prevention that really gets at those upstream drivers of health. I think Abe Sutton also highlighted the need to think about strategies that can be implemented in constrained fiscal environments, and really understanding, therefore, which strategies are able to save resources, which one require greater investments. And so maybe actually, Secretary Sangbai, I would start with you on this question. North Carolina has been doing a lot of work with its Healthy Opportunities pilots and thinking about upstream drivers of health and what can be invested in. Would greatly value your perspective on what have we learned and what does that mean for others who are thinking of similar initiatives?
Yeah, that's a great example. So my predecessors had the foresight to say, let's take advantage of the 1115 waiver opportunity in Medicaid. So we did that in North Carolina several years ago, do these things called the Healthy Opportunities pilots. We have 3 throughout the state. One actually that launched in the western part of the state that many of you might know has been further complicated in the aftermath of Hurricane Helene. What we demonstrated through the 1115 waiver is that if you make the right investments in things like food, behavioral health, stress, transportation, you can actually bend that cost curve, some of what we heard earlier. We were able to demonstrate that there is early cost. You spend more early on, we all know that, but by keeping patients out of the emergency room and other settings, you actually start at least slowing the cost growth, if not bend the cost curve. We have validated data. It was actually published in the Journal of the American Medical Association that demonstrates that you can save on average $85 per beneficiary per month at the steady state. So we think programs like that are crucial. One of the other things, I'll go back to the economic engine part of it. When we started offering food boxes to individuals, we actually relied on the rural farmers to produce those food boxes. So here we had a Medicaid strategy that was designed to increase and improve health that actually had local economic impact as well. And it'd be great to see how to expand something like that and see something like that go nationwide.
And I think Healthy Opportunities is also a good example of where you've been targeted specific preventive services to look at that evidence base on what specifically can improve health in a quick manner. Maybe Jenna, going to you also building on the fireside chat, a lot of that conversation was looking at new ways of using value-based payment or other types of accountable care. And I know you've done some thinking along with your members in terms of how that looks for the safety net, which has a number of nuances for how that actually plays out on the ground.
Right. I think if you're interested in modernizing Medicaid and making it more efficient, you have to engage with the safety net providers. And there's some unique challenges with that. But I really view value-based care and moving health centers and other safety net providers in that direction is really what's going to save us, because right now the safety net is struggling. And I've worked with health centers for about 30 years. I've never seen them this financially strapped. And it's become increasingly challenging for them to not even make a profit, but be able to make payroll in some instances. So I think value-based care is part of the answer there, not only for improved health for our patient populations in our communities, but for their financial viability in terms of safety net moving forward. That being said, we have some unique challenges as we engage in value-based care. We don't have a lot of revenue to be able to invest in the infrastructure that's necessary. You've got to have data analytics. You've got to have population health platforms. You have to have care management. You have to have patient engagement tools and staff to be able to help you be successful. And as a safety net provider, you often don't have the resources to be able to do that. So what we have done in Texas, and this is actually happening across the country with community health centers, we are coming together in clinically integrated networks in individual states where they're FQHC led and controlled. And so we can learn from each other, spread risk across the different safety net providers in our network, come together to try to leverage federal, state, private resources to be able to build that infrastructure that's necessary to be successful. I know a lot of models use enablers, which I think are great. They can, if you're really interested in getting there quickly, I think that's the way to go. But if you're really interested in having a sustainable model in a low-income, medically underserved, economically disadvantaged community, which I think, to your point about economic development, we need to be focused on that as well in the communities that we serve. You really need to invest directly in the safety net to be able to maintain those resources there so they learn how to do it. They own the infrastructure, they own the contract, they actually get to benefit and their patients benefit directly from participating in VBC. So that is something we're doing. It's the hard way to do it. But I think in the long run, I think we're going to be more sustainable if we invest directly into the community, into the safety net. So that's what we're attempting to do, and it's happening all across the country.
And Toyin, turning to you as well, I know in your opening question, you noted some of the issues in thinking about aligning incentives for high-need older adults like that you work with. Would be interested to hear the nuances or maybe the similarities with the population you serve.
Absolutely. So they overlap very much, right? So the majority of people who are dually eligible, particularly after you get outside of sort of urban settings where primary care is scarce, are served in a community health center or a federally qualified health center or some such. We see a lot of folks also who are served in health system affiliated primary care practices. And so these are folks who say developed a life-threatening condition, were hospitalized in an academic medical center, were then referred to outpatient primary care. All of that works on paper. In practice, when you meet these folks and you actually look at the data, less than half of a high-risk population has had what we would consider meaningful primary care, which means they haven't seen their doctor in the last year. And if you're walking around with diabetes and heart failure and hypertension, and you're hospitalized 5 times last year and you haven't seen your primary care doctor in the last year, I don't care what name is on your card, your insurance card, you don't have primary care. And that number has been going down over the past few years. We have workforce shortages for sure. We have access problems for sure. The pandemic really threw everybody for a loop. Even today, I mean, lots of folks in well-insured folks in commercial plans have a hard time getting primary care. But there's another piece underneath that, which is the value proposition for these members and these patients. Many of these practices, for better or for worse, and a lot of it is they're constrained by their own economic structures. I'm a primary care doctor. I practiced in FQHC for many years. I have a lot of empathy for this. But when you're saying to somebody who is struggling with 3 or 4 chronic conditions, maybe has a mental health challenge, is caring for a bunch of kids at home, to take a day off work, so not get paid, find somebody to watch their kids, pay for transportation, come to the doctor's office, wait for an hour and a half to get seen, and then get 10 minutes of this and a lecture about how they should exercise more and eat better. Why would they do that? They don't, right? They'll wait until things get bad. They'll call and the doctor's office will say, we can't see you for 6 weeks. I'll go to the emergency room. And what we've done is we've created a system where the default, by design, frankly, is for our most medically and socially and psychiatrically vulnerable people who would benefit the most from longitudinal community-based primary care and mental health. We've created a scenario where the default for them is to go to the hospital. And so what we have built in our model, and what I think should be the model, frankly, for all of these folks, is an understanding that we have to catch them in the community where they are. And we cannot simply wait for people to come to us and demand that we take their most precious asset, which is their time, and not deliver something that's valuable to them in return. We have to go to people, meet them wherever they are, in whatever form that means for them. We have to actually earn their trust, which means spending the time to prove that we are there for them. We have to be always on 24/7, which means if they call us in the middle of the night with a problem, somebody clinical should be able to answer that concern and solve it immediately as an alternative to the emergency room. And we've got to be able to do that consistently every single day of the week. And until community-based providers like our FQHCs and primary care doctor practices and our academic medical centers have the alignment of resources and incentives and have made the investments to be able to deploy a model like this, these folks are going to fall through the cracks. And so what I think we have to do is both, right? We've got to continue to strengthen the primary care infrastructure. We have to teach people how to do things totally differently. Primary care is one of those things that is shocking to me that it has not changed at all in 50 years. Right? Today, I can order food on my phone, it delivers to my house. If I want to go to get, cash a check, I go to my phone, it's there. Nothing looks the same as it did 50 years ago about the way we interact, except if you're sick, you got to call somebody, wait on hold, wait for them to schedule an appointment, go to them, wait for them, like why, right? And so with the addition of technology, but also with new models of care, we should be way ahead of this. We should be much further ahead. And I think there's certainly incentives we can make in the way we pay for healthcare and we design healthcare. But we have to accept that this is a place where I think the insurgents have to be given as much room and as much fuel as possible to lay the foundation, start to show people what it can look like. And personally, for me as a physician who is deeply passionate about making sure that we do right by these folks who live in the shadows and maybe left behind, the entire motivation for building our company, frankly, was to prove to everyone that not only is it possible to do it better, but that we should all be embarrassed that we haven't done more. Right? And so if we can continue to sort of support and invest in these types of models that work in partnership with the existing infrastructure to say, this is where we can go, and we'll go as fast as we possibly can and shine a light and lay the path so we can all get there, I think hopefully we'll start to move things forward in the way they need to be.
Thank you. And I got a question from the audience, noting that we've talked a lot about upstream prevention, we've talked about nutrition, we've talked about other factors. And then this question may go to Stephanie, where does CMS policy fit into this? How do you create the investments? How do you create the ecosystem? What can CMS do to improve nutrition or help with lifestyle supports and the like?
Yeah, I think you spend any time in Washington, and I think the media and politics get involved and say the answer to that is just dump more money into a system that is not serving vulnerable populations well. And I think what our team is really trying to do is sit back and say, how do we fix the system so it really works for people? One of the reasons I really enjoyed getting to know Toyin is she puts her money where her mouth is, and they've done really innovative work to understand vulnerable populations and think creatively, not just about adding more primary care doctors, which is important, but how do we help those primary care doctors be more productive and better meet the needs of their patients? That's starting to think about value-added competition that's changing the system and really changing the health outcomes. And those are the kind of models that we're really excited about in CMMI, in Medicare, with our duals population, and very much so when it comes to Medicaid. And I think Medicaid is a program front and center right now with all that's happening in Congress, where I think the easy answer is to say, well, Republicans just want to cut the program, Democrats just want to spend more on the program. Neither answer is actually making people better and getting better health outcomes with the money that we're spending. I think really tackling how do we think about this differently is, I would say, our number one priority is thinking about how does technology really change the whole paradigm for how we deliver care. Toyin's right. We're still delivering care the way we did 50 years ago. We're still delivering care really the way we did when Medicare and Medicaid were created in the 60s. And that's not keeping up with what's possible with technology. As you think about 97% of Americans have a smartphone today. The vast majority of actually low-income Americans have a smartphone today. Why can't we make it easy for them to access technology that knows their medical history, that knows the medical evidence, that's connected to real-time data that their caregivers can see, and then actually personalizes medical recommendations for them that they can touch on their smartphone, at midnight. They don't have to call and wait to go into the doctor, but that actually gives them access to care where they will use it day to day. And I think there's use cases for that in prevention for people who are generally healthy or they don't know they're sick, we'll put it that way, as well as people who we know are sick and need intensive medical care to manage chronic conditions. And I think those are the kind of things that we're very interested in our technology agenda that start to just completely transform the equation and the value that we think we can get out of our healthcare system.
And I think on a related note, another question we've gotten on from the audience here ask about provider participation. So we have seen over the last 5 years, it's been a very hard time in the healthcare workforce. We've lost a number of practicing providers who've left. There's a rampant rates of burnout and stress. So we've talked about a lot of great ideas of how to improve care, but how do we make sure that we have the workforce that we need to be able to do that? And how are we supporting that workforce? And maybe turn to the panel here. I see, Jana, you nodding the most. I'm going to pick on you first.
Yeah, we figured out a long time ago, being in medically underserved areas, serving the population that we do, we're at the end of any kind of workforce pipeline. So we figured out a long time ago, we're going to have to create and build our own. And so I think it's really important if you're really wanting to expand access and get the right kind of providers in rural Texas or rural Minnesota or frontier areas or poor inner city areas, that's where you need to really be providing the training to expose different levels of clinicians to that work. It is a work of passion and love, and I hear it in your voice, and that's certainly the way I feel too. It really gets you, and you want to give more, but people have to be exposed to it. The other thing we are doing, and it's not just about creating, like we have a lot of family practice residency programs and other OB programs, et cetera, which are really important, and we need that. But we also have tremendous shortages with allied health professionals and other really important members in our care team. And so we have started apprenticeship programs where we do upskilling basically for our allied health professions with community health workers or the receptionists that really want to pursue a nursing degree, but they don't really know where to start. So we're doing MA, dental assistant programs, doulas. We have a serious maternal health challenge and shortage of care in our state, and I think this is across the country. And so we're training doulas and community health workers. They're really critical parts of the care team, and so we can't always just depend on that physician. We want that physician to be working at the top of their license, but we need that whole care team. And that's also how we have really good outcomes as well and better patient engagement. And so we have just started all these different training programs. We're also partnering with the private sector, community colleges. We have a lot of veterans in Texas that are coming back that have a medic health background, where there's innovative programs where they can work with a community college and a health center, so we can get them up to speed to get licensed to be able to practice in our community. So we're kind of throwing everything we have at it because it's such a significant problem. But I hope you heard my point. It's not just about physicians and nurses, absolutely critical. It's about dentists, it's about pharmacists, it's about the community health worker. All those are absolutely vital to the goal that I think everybody on this stage shares.
And maybe Steph, I know you have some thoughts, and then actually Secretary Singh, but I'd love to get your thoughts, especially in rural areas. But Steph, thoughts on from CMS's perspective?
Yeah, love the creativity and how we think about the pipeline of talent in clinical workforces. I would just build on that by saying for the talent that we have, how do we make them more productive by being able to focus more on patients and what really matters, rather than so much time. I used to be a labor and delivery nurse, and the amount of time you spend charting and focusing on that for technology. We've got ambient charting capabilities that really enable doctors to come out of a meeting and have well-structured notes that just have to check. Think about the amount of time that can save the talent that we do have. I think there's a lot that technology can really help with that, as well as some of the ways you can use generative AI to sort of extend the clinical workforce that we have. So I think thinking about these workforce challenges from multi-dimensions really starts to help crack the code longer term.
Yeah, I think that's these are great examples. I ran a Medicare shared savings program for about a decade, and one of the selling points was, hey, if we all work together, there may be some little bit of shared savings at the end for you. And what I would consistently hear was, I'm not sure I want the shared savings. Can you get me out of the office at 5 o'clock with no homework? And so when you hear about these technology tools that we want to use to be able to do that, and a decade later, it really hasn't changed much. So I think, these opportunities to really feel about how we sincerely engage the entire provider community to say, we understand the stress, the burnout, we want to make it easier for you. And I think it's on the patient side as well. It strikes me that, the comment that was made about all the burden, we still fill out paper forms every time you go to the doctor's office. And I fill out the same ones at the same doctor's office every single time. And by the way, there's an electronic survey that includes those same questions that I think I'm doing on the front end before I go to my appointment. We got to really rethink what it means to be a provider and really de-burden the administrative stuff. Two things I would add to what was already said. I think on the professional side, there's real opportunity to rethink higher education and what it means to be a professional, whether it's a physician, whether it's an NP or a PA. We use a system, and this is just me talking personally, but we use a system that uses time and not competency to figure out if somebody is ready to do something. I think we've all ran across professionals who in their second year of however many years of training was an absolute superstar and needed to go out and really take care of patients, and others who in their nth year of however many years, you were worried whether they were going to be able to do it. So I think we really need to rethink all of that. And then the final piece is on the front end. I think we need to rethink how we fill vacancies. Those jobs we have today that are primarily entry level, and those individuals going to the jobs are not going to be in those jobs in the future. So I use my experience as a hospital CEO. We would hire CNAs. The turnover rate for CNAs was roughly 60%. In the 1 year. So it means 6 out of 10 a year from now weren't going to be there. So gone is the career CNA, gone is the career MA, and they all want career advancement. They want to do something different. So one of the things we need to do that I'm focusing on is how do we actually curate a career for you? So if you want to leave the bedside because you want to do something in management, let's find something in this hospital. Let's find something in this health system. Let's find something in this industry that keeps you here so that we can create that stability in the workforce. Unfortunately, that takes time and effort, but I worry we spend so much time on filling vacancies, hiring managers, incentives, how do we compete and so forth. And what we really need to do is to say, how do we embrace you as part of the workforce and grow that 30, 40-year career, which is going to look entirely different at the time of retirement than it did at the time you started your job.
And Twin, yes, I was
just
gonna
a
say,
couple more things. I agree with all of these points. I will say, as a physician, I think I can say this. I think we have done everyone a disservice in terms of the way that physicians and the associations that represent us have thrown just like roadblock after roadblock in the way of leveraging other people to provide care. So I'll give you a couple of examples. 10, 15 years ago, probably the first papers were coming out that demonstrated that nurse practitioners were as good, if not better, at managing uncomplicated chronic disease management than physicians. What did physicians do instead of saying, thank goodness there's more people to help us take care of all these sick people? They started to throw up all kinds of reasons, licensure, scope of practice, you name it. 10 years ago in Massachusetts, we were looking to figure out a way to get paramedics and EMTs, who, by the way, are some of the most incredibly skilled clinicians we have in our workforce, who are essentially paid to transport people. They do not get reimbursed if they don't transport somebody from the scene of the accident or injury to the hospital. We said, well, look, these folks can call STEMIs, heart attacks in the field. They can call strokes in the field. They are clinicians. They should be able to treat and leave people there instead of taking them to the hospital if they don't need to go. Who blocked us? The nursing unions. And the nursing agency said, no, 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 this is beyond scope of practice. Only nurses can do this kind of stuff in the home. We've got to figure out as a community of practice in healthcare, how do we allow every single person who is willing to spend their career in service of caring for other people to practice at their scope, the top of their scope of ability? And let's really continue to reiterate and reevaluate that, because with technology, with tools, with decision support, with telemedicine, folks who didn't go to medical school can do things that we thought only doctors could do 20 years ago. So why are we not evolving and allowing them to do that work? We're going to have to. And so I think there is something here from a regulatory perspective. State by state, the medical boards have a lot of control about how they think about who can practice and who can do what. At the federal level, I think we have a lot of really important levers about how we reimburse different types of people for different modules of care. We have an opportunity to think very expansively about, we have a crisis, it affects all of us, all of us. How do we think about taking advantage of all these incredible people and allowing them to practice really at the top of their capability and not being constrained by, did they go to 8 years of medical school and residency and what have you, to do the thing that actually doesn't need any of that.
And we have to stop here just in interest of time, but want to take a moment to thank the panelists for such a great and engaging conversation.
Great, thank you.
We are going to move on and talk about supply chains next. And thank you all. Oh, note I've given our organizers, there are plenty of seats, especially on this side of the room, so folks consolidate a little bit. We'll be able to fit more in. But thank you all.
Thank you. We don't have a slide.
Do you have a preference? Okay. Fantastic program so far. Really looking forward to this next session on essential medicine supply chains. Let me just pull up my notes here. Okay, there we go. So I'm Stephen Colville with Duke-Margolis, where I lead the Revamped Drug Supply Chain Consortium. Got a fantastic group of panelists today. Ron Piervincenzi with US Pharmacopoeia, Chip Davis with the Healthcare Distribution Alliance, and Sarah Dorsey with Fresenius Kabi. Unfortunately, our fourth panelist, Stacey Sanders, is not able to join us this afternoon. There's a little thing called reconciliation you might have heard of recently that she's dealing with in Congress at the moment. But Stacey did share some thoughts with me that I can pass on to you, relay at the end of this conversation. So let's get into it. Drug shortages, they're really impactful from a patient care perspective. Like when you go to a hospital, you expect that essential medicines that you need are going to be there when you need them. But unfortunately, just too frequently, there's a supply chain challenge or something else that happens that causes that drug not to be available. And there's some really impactful instances of this really severely impacting patients and really poignant examples. One of which is my good friend, Laura Bray, who's a mother from Tampa, Florida. Her daughter was diagnosed with leukemia, like a worst case scenario as a mother. And then on top of that, they experienced as a family 3 separate drug shortages during their journey through the chemotherapy treatment, where the patient needs a drug and it's just not available due to a supply chain challenge. So it's a really obviously difficult, very painful situation, and something that I think we should keep in mind as we think about policy solutions in this area of how can we avoid that sort of situation happening again. And this is a longstanding, enduring problem. Very much looking forward to getting into the conversations around the causes of the problem, what solutions can we put in place, and also other relevant policy topics that touch on and have impacts on this area, like tariffs, conversations around tariffs and onshoring of pharmaceutical production, and also the drug pricing executive order from earlier this week. So I'll start off with a question for Ron, and then work our way down, if that's all right. So I think the audience will get to know you all a little bit better from this first question. If you could just speak to your role and your organization's role in building a more resilient drug supply chain and one that has a better reliable supply for patients.
Yeah, thank you, Stephen. Thank you, everyone. Thank you, Mark, for speaking at our convention this week. So you described a situation which is our reality today for very unique drivers, but USP was founded literally in 1820, just a few blocks away in the Senate chamber, because the US drug supply in 1820 was fractured, problematic, poor quality, medicines being dumped from Europe, especially from England, and a group of 11 physicians who are also patriots, 2 of whom were former members in the House, actually. They came together and formed the world's first national pharmacopoeia, which is basically at that point a set of recipes, and today is thousands and thousands of standards that make what a generic medicine you get be exactly what it says it is, something you take for granted. Today's drivers for challenges are different, but the passion for having supply chain resiliency work is incredibly important because a patient is entirely unequipped to have any idea what's in that bottle. They have no choice but to have utter and complete trust. And it makes the system so much more important than in most things in people's lives when they have more agency in their choices. Thank you, Stephen.
Thanks. Chip?
Stephen, thank you, and thank the Duke-Margolis team. My name is Chip Davis. I'm the president and CEO of the Healthcare Distribution Alliance. We represent healthcare distributors in the United States, both those that move pharmaceuticals, biologics, generics, biosimilars, as well as medical supply products to a lesser degree. Our organization is not quite as old as USP, but next year we'll celebrate 150 years, so 1876, if I'm doing my math correctly. And we have a unique position, I think, well, let me start with where we're aligned, right? I think, as you articulately stated, Stephen, any drug shortage for any patient is unacceptable. And I think irrespective of where you are along the supply chain, as long as we all come at it from that perspective, we're going to be able to work our way through. That's not to minimize the real challenges that we have seen over the last several years, although there have been periods of time where some of the pressure has been alleviated. Our members, we have 38 distributors who connect upstream to the pharmaceutical manufacturers, as an example, some 1,200 to 1,300 every day. And then they actually distribute and deliver product after purchasing it, taking physical possession, legal title to it, and then cascade it downstream to over 300,000 sites of care every single day. If you place an order with one of our distributors by 6 p.m., it will be there by 8 a.m. the next morning. We have a reliability rating that Amazon would be proud to have. I mean, that's the level of the logistics expertise in our members. With respect to drug shortages, one of the things that if you are experienced in this area that you will realize is if you have seen one drug shortage, you have seen one drug shortage, full stop. There are supply side drug shortages that can often be driven by manufacturers getting out of the market or perhaps an inspection where they have to shut down their operations for a period of time. And we've also seen demand side shortages, predominantly in the generic space historically is I think where we see them. And I think there's a larger that I'm sure we'll get to discussion around what I believe is needed to be, having worked in both distribution and in the manufacturing side, both brand and generic. There is a real need from my perspective here in the US market to have a reset or recalibration on the value proposition of generics when they are 90% of the prescriptions written in this country and less than 20% of the total cost. There is an argument, and I respect, and we'll talk about the EO that was issued yesterday by the president. It's actually the second one in 3 weeks on prescription drug costs, and high drug costs are very much an issue, but so are low drug costs. And I think that's one of the things that we're going to have to realize is one of the economic drivers that is impacting the shortage situation here in the US.
Okay. Thanks, Jim.
Thank you all for having me. I'm Sarah Diorsi with Fresenius Kabi. And to kind of piggyback on what Chip was saying, we have a unique way of looking at manufacturing. Most of our drugs are local for local. So if we're serving patients in the US, we're manufacturing those drugs in the US. If we're serving patients in Europe, we're manufacturing in Europe, and so on. The challenge that we've had in the past, I would say 5 to 10 years, is our cost to manufacture in the US is above the average sales price of that essential medicine in the market. And a lot of those drugs are coming fill and finish from China and India, where there are a lot of government subsidies and just the lower cost to manufacture there. And so we're thinking, how do we stay competitive in this market and still update quality systems, still do things that we do for resiliency? For example, we hold API, we have lines open in case somebody else has a shortage. Many times we've been the ones to step in to fill some of these shortages. But it gets to a point where we cannot have our products price per unit dip below the cost to manufacture. And so that's something that's a challenge that we've had for quite some time. And we're working very hard on the policy side to get some awareness on how these drugs should be valued and how resiliency should be valued.
Great. Thank you so much, everyone. And let's double click on the problem here. And I think Ron, I think you'd be a good one to speak to this again as well, and then others can absolutely chime in too. But can you frame up the problem for us? What are the main drivers? How should we think about that, and how can that inform our solutions?
Yeah, it's interesting. There's two ways to look at it: the drivers piece and the correlation. And let me start with the second, actually, before the drivers, because Chip, you spoke a bit about the drivers coming sometimes supply, sometimes on the demand side. But there's something else if you're looking forward and you're trying to predict, which ultimately the only way to stop these shortages is to be predictive. Otherwise, you're chasing yesterday's problem. And we actually know the answer now. We've done the math. We did the work. It took a few years, but we've done the work. And the first, actually, and by first, I mean the thing most highly correlated with shortage problems is too low of a price. That is number one. And there's a whole series of logical reasons that come. If the price gets too low, people exit the market. It's not that complicated. You don't need to be an economist to figure out why that might happen. The second, most likely, is complexity. Now, importantly, this is not complexity in how the medicine works or how it serves or even the disease. It's literally just how hard it is to make it and ship it, really distribute it. But the complexity on that front, the higher that goes, the more the problems are, the more shortages. And then the third and the fourth are a little different. The third is geographic concentration. And we see that in terms of a tornado or a hurricane. But that could also be a factor in geopolitical challenges or even in worldwide disruptions, think pandemics, climate change, and things like this. And the fourth just went out of my head. So I want to come back to that one later. So to come back to it then. So these are things that help us predict. When we look at the drugs that are most likely in shortage, very rarely is it actually one of them. It's often two or even three. And those are the ones that are in chronic shortage. We have medicines today that have been in shortage 8 of the last 10 years. That's incredible. And you think, well, why doesn't the market fix it? Well, we don't truly have a market on these generic drugs because there's no such thing as a generic market. There's 1,000 markets. They're not interchangeable products, and therefore they're not the same market. They're different markets. And there's 1,000 markets. Some of them are working quite well. Some of them are so-so, and then some are failing miserably and chronically. But because there are not that many, per Chip's point, it can be solved. But we have not created any incentives for people who are doing the right thing to preserve that resiliency of those medicines so far.
So you're focusing on the large section of the market that's generics. 90% of prescriptions are generics, where actually costs in the US tend to be lower than other high-income countries. And so that's one problem. There's also the separate problem of branded drugs that are higher priced in the US compared to other high-income countries. But it sounds like you've seen most shortages occur on that low-price drug category, which actually is most drugs that Americans take.
Demand-based shortages, GLP-1s are an example we all see in the last couple of years. They can happen, but on the branded side, there's an economic incentives are aligned. They get fixed. And they actually do happen less often. So mathematically, you can see that. On the generic side, it's a shared responsibility. And like anything, if you have in your own family, if you share the responsibility of taking the garbage out, half the weeks, no one's taking the garbage out. And so in that sense, there is a shared responsibility. And therefore, who's on the hook to fix these problems? Well, if the product is priced below your cost of production, nobody is going to fix it. And that's why you have chronic shortages.
So Sarah, maybe I'll bring you in here to talk about your perspective on the problem as well, like we were talking about, but also how do we start to move the conversation towards solutions? Like, what do we do to solve these long-standing issues?
Yeah, I mean, I think what Ron says is correct. And we have a lot of acute care drugs, so sterile injectables. That's our biggest business. And most of our drugs are on the essential medicines list. And because we're selling to hospitals, you have a hospital that's under price pressure. And for example, 85% of their drug spend is on brands, 15% is on the generics like we make. Oops, sorry. For the brands, there's nothing, they're on patent, there's no substitution. They cannot push those prices down. So they have to go to the 15%. So when you open up a database and you look and you say, okay, this one's 3 cents cheaper, blah, 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 you know, that's what we're going to use to decide what we're buying. And I think a solution would be to give some more awareness and an incentive to choose a drug, maybe not just on price, but also on a resiliency standard. And it doesn't always have to be where it's manufactured. Does the company have contingency in place in case there's a shortage? Does the company have some extra finished dose? Do they have a stock readiness? Those types of things. And once we start doing that and valuing that resiliency piece, price is also important. But if we're valuing resiliency, we may be able to come up a little bit, you know, a couple cents on price. Other manufacturers who manufacture in the US can come back into those markets, and we are done with shortages.
Right. I mean, there's a lot of similarities or themes to value-based care that I hear to what you're talking about. You know, how do we think about things holistically? But Chip, let's bring you in here as well.
Just to carry on from Sarah's comments, I think one of the interesting things when you live between the manufacturers and the providers, full disclosure, we're not the middlemen everybody in Washington likes to talk about. So park that there for a second. But the reality is we may not always be the first to see a shortage, whether it's coming from the manufacturing side, the supply side, or the demand side. But we're often the first one that gets the phone call. You know, if a manufacturer is having a problem, they're going to call their distributor and say, we're about to have a problem. You need to go find a secondary source. Or alternatively, on demand driven, you'll hear it from health systems, hospitals, pharmacies, and the like. So it puts distributors in a bit of a unique position to be able to make sure that that communication flow is effective both upstream and downstream. Specifically to what Sarah was saying, I think the reality is, and it's a fair comment, that there is so much cost pressure on every entity within the supply chain that over years and decades, we have in the United States essentially moved to what we call a just-in-time inventory. You're going to keep, whether you're in the manufacturing side and you're determining how much to manufacture, you're going to manufacture just enough to think that you're going to meet the demand. In my world, in distribution, you're going to purchase, you're going to possess, you're going to carry, you're going to inventory, you're going to store in temperature-controlled environments, enough inventory to meet demand. Pharmacies are no different. Can we, in certain instances, perhaps starting with the list of essential medicines, as you articulated, actually shift from just in time to just in case and create more resiliency, more redundancy, which is a word that usually causes an allergic reaction in the generic market because it operates as lean as it does. So that's when I was talking about kind of the need to recalibrate or reset, I think, but you have to make sure that this is a discussion that goes beyond manufacturers and frontline buyers. Because if you were to poll everybody in this room right now and say, hands up, who wants to pay more for generic drugs? I don't think you're going to get a majority of the people in the room. And that's not a criticism. That's just the reality of what we've been dealing with for the better part of the last 2 decades or so.
So Chip, I'll stay with you. Thanks for those great points. Like, what are some steps that we could take to move towards more resiliency if there is an additional cost that's inherent in those steps, but they're important to take? How do we do that? And we mentioned a few different aspects of resiliency as well: redundancy, inventory levels, risk management plans, location of production. Sarah, you mentioned that's a portion of that as well. I'm wondering if you could speak to those different aspects of resiliency, and especially that last piece too.
To kick it off, and I'm sure my colleagues here will have even more articulate things to add. I actually think in terms of looking at the current situation related to shortages, that, and again, Sarah mentioned this earlier, like the reality is in a globally competitive market, when you have markets like India that are subsidizing its sector, that's something that we have to acknowledge, right? The labor costs are lower, the environmental regulatory standards are different. And that's one of the reasons why We didn't get here overnight. There's all the talking about, onshoring or nearshoring. We didn't get here overnight. This has happened for the last 3 to 4 decades. I applaud the administration for looking to bring it back, but we also have to be realistic about the time frame. So I think those are two things that have to be reconciled. I think the other aspect of this, which is really important to make sure of, is that, and you've heard a little bit about this already, is historically, if you go all the way back to when the modern day generic industry was created through Hatch-Waxman back in the mid-'80s, the goal was we wanted innovation, we have strong intellectual property, the patents expire, and then generics come to market, and generics have access, market access. That's not guaranteed anymore.
Yeah.
When a generic gets approved, when a biosimilar gets approved, there's no guarantee they're going in preferred positions on a formulary, which translates into lower copays for the patient. What sense does it make, in my view, to have a patient pay a higher out-of-pocket expense for a follow-on competitive product than the originator product it was designed to come to market to? That's number one. Number two, you've heard this discussion around quality and quality measures. I can assure you, as someone who represents people who purchase product, yes, they want a good deal, but you know what they want? They want reliability.
Yeah.
So you're seeing more and more of that being worked into the system, where they will be evaluating, not systemically, but because it's a competitive industry, but individually, who is reliable. Fresenius Kabi, high reliability rating. I'm not just saying that because Sarah's here, but the reality is they do. They have a great track record, and that makes them a good partner to work with through good times and challenging times alike.
Mm-hmm. And you do have a big domestic manufacturing footprint as well. So how does domestic manufacturing play into the conversation here?
I mean, like I said, we have a local for local strategy, and we have over the years been the company who comes in. There was a giant heparin shortage many years ago where we were supplying the entire globe with heparin because there was a contaminant in China for API. Our API was diversified. We had some in Italy. We were able to use that API. Our fill and finish was here in the US, and we were able to ramp up. But this problem has gotten so bad and the price erosion so difficult that I don't know how many more times we would be able to do that. And, I think Chip is saying no one wants to pay more for drugs, but, the cost to a hospital of dealing with a shortage and putting people on different drugs to try to, match the one you don't have, that costs you more. So I think just getting a more long-term view of reliability and valuing it up front is going to save you money in the long term. And Chip, I agree on the branded drugs. The best thing for a hospital would be to cut down on that 85% of their spending on drugs. And that means patent reform. That means a lot of things that lawmakers have not wanted to do, but it's a real problem. I mean, biosimilars, we're talking about the most favored nations. The problem is that Europe doesn't have patent thickets or any of those things. So biosimilars on the market for 5 years before we are in the US. So it's not a us versus them, whatever. They don't have patent abuse. They also don't have the other middlemen. But,
So
didn't mean to start something. Sorry.
So let's go into tariffs a little bit more and potential impacts there. So obviously there's been tariffs applied and removed on a variety of products, tariffs proposed on pharmaceuticals. What do you see as the potential impacts there, and how does the potential impact vary across different product categories too?
For us, we're in a very good position for tariffs, but what we would like to see happen is going after the root causes of what actually causes this. If there are tariffs, we believe that you've got to look at this 232 investigation should be looking at the cost to manufacture differentials in different places. Probably
And
Europe.
that's the investigation looking into what the potential path forward for pharmaceutical tariffs might be.
And so an outcome that would be surgical and maybe helpful would be to level the playing field between the cost to manufacture in China and India and the cost to manufacture in the US, level that, have all those inputs be equal, and the purchaser makes a choice based on reliability. That would be great. But if it's not surgical, it has a very scary impact of causing a lot of shortages.
Mm-hmm. And Ron, we'll go to you as well on the tariff conversation. I know your team has done a lot of work looking at potential impacts here. What do you see coming forward?
So maybe I could share a little of the facts underneath it, which I think point us to the next questions. the USP's medicine supply map, which was created beginning with finished dose forms, bent medicines, and moved upstream to APIs, the active ingredients, and now has even begun working on key starting materials, which basically the chemicals that are then used to create the API. Why does this matter? Well, it matters for two reasons. First, the tariff has to apply to something, and it's a complicated world, something I didn't really know very well until the last few months. And typically it applies to the API. But that might not be the most important part of a medicine in a constrained environment where the key starting material is only available in one place in the world. This is actually surprisingly common. So to share a few numbers, the USP Med Supply Map just finished an analysis weeks ago even that mapped the entirety of the API. Where is it coming from? We know who can make API, FDA has this data and others, but knowing who does is a massive difference. So a tremendous amount of API holders are in China, but only 8% of the volume, 8%, single number, 8% of API is coming from China. Most API is coming from India. However, within China is the making for at least 50%, perhaps even more, of the key starting materials, the chemical materials that are used to make the API. And therefore, if you back upstream, you see very differences. So then the question comes not just for tariffs, but for anything when you think about geographic diversification and security, especially on security, the answer of where does the medicine come from is almost a useless question, and you have to go much deeper because Fresenius Kabi is an outlier, a positive one, but it's an outlier. And of course, I know you know this, that the vast majority of the rest of the supply chain will track back. So then finally, the question is tariffs or any other incentive, what are you tying it to? And USP for 205 years has had a mission about medicine quality, and the driver I forgot was quality. So first, the board should fire me. Second, quality does matter because it's the thing that the customer, in this case the patient, is least able to measure, the most thing that they rely on, the trust. I bring it up because guess what? It can be measured. We have ways to measure. The FDA measures it every day. There are other measures as well. They can talk about the quality of that supply, quality of the medicine, but the quality of the supply, the resiliency, the plans that are in place. And we've begun a set of metrics with a few partners. Fresenius is our best partner in creating what that benchmark could look like. And now it's a tool that the distributors who are also involved can start to point to and say, there is a way you can measure, you the buyer. And it comes in the end then finally to the buyer. And in this case, we don't mean the patient, but we mean the entities that are making the big purchasing decisions that represent the patient. Could be a health system, can be pharmacies, it's also complicated. But in that case, they're saying they want to help pay for resiliency, and they don't know how. So right now, we think the number one solution is to be able to put these resiliency benchmarks in front. This is a private sector solution, but I think the governments at state and federal level have a chance to give it a shove. But it's really a private sector. So it's possible. It's right here. And I'd say it's available in months, not years.
Yeah, and I mean, I would just say that this very situation happened several years ago with anti-infectives. Yeah. So there was no market for branded companies to develop new antibiotics and antifungals because the whole purpose of them is to not have to use them. Yeah. Right. So there was no money in it. There was no margin.
Congratulations, no sales.
Right, exactly. And so you wouldn't really, there was no guarantee you'd recoup your investment. But with superbugs and things like that, it's a potential disaster for the US to not have new antibiotics and antifungals. And so Medicare put a condition of participation into their regs where hospitals and other clinics would kind of comply with stewardship and they would buy a certain amount. It sort of propped up the market. And what we've been talking about with USP and others is trying to replicate something like that as an incentive for generic essential medicines, because again, when you don't have them, there's a big problem. But there isn't necessarily a healthy market.
Good. Yeah, absolutely. So I want to make sure we have some time for me to share relay thoughts from Stacy. And actually, her thoughts relate very similarly to the discussion we were just having, which is, recent proposals around new ways to value and pay for resiliency, because we recognize, these steps cost money to have redundancy and strong investments in quality culture and that sort of thing. So there was a bipartisan draft in the Senate Finance Committee about this time last year around a legislation that would get at this problem. So want to share some thoughts from Stacy here. Last year, Senate Finance Committee released that discussion draft that I mentioned to address unsustainable low costs and shortages of generic medications. And the bipartisan Finance Committee staff are in the process of reviewing that feedback and are working on updating their discussion draft. So she's grateful to everyone who's been a constructive partner in that process. But she wants us to put this work in the context of the broader current policy environment. She expresses concerns around potential adverse impacts of tariffs on drug availability and cost, expresses concerns around organizational changes at HHS and FDA on their ability to accomplish their mission and the elimination of offices that we're working to coordinate interagency efforts on drug shortages, and then expresses concerns around how meaningful and implementable the recent executive order to streamline regulations for domestic pharmaceutical manufacturers could be. So she closes by saying it's difficult for her to envision Congress being able to implement new policies aimed at drug shortages, given those other challenges, and also reconciliation also is on the table right now. But I think Duke-Margolis is, these are hard problems, but Duke-Margolis is well positioned to help move the ball forward. And we're going to be working on this problem over the next few months and helping to refine these policies proposals that we've been discussing, and getting it to a point where it can be implementable in the future. So we have just 1 minute left for a rapid fire closing from all of you. If you can maybe just hit one or two items that you think really stuck out to you from this conversation that you'd want others to take away. So Ron, go to you.
We've done the thinking. It's time to implement. And the solutions can be, I would think, 90% private sector, but there needs to be a kick to get from zero. We're stuck on zero on action, and we need to just get something going. And I actually think it'll be self-sustaining, because it is not unsustainably expensive to be a high quality producer, distributor, or dispenser of medicine. But if nobody's doing it, anybody who tries falls back because they're not rewarded.
Yeah. Chip?
Yeah, I think just one more thing to think about, just touched upon the issue of tariffs and the Section 232 investigation, which is being led by the Department of Commerce. Oftentimes those studies take multiple months or a year to play out. We expect that will not be the case here, given the sensitivity to this issue by the administration. But one of the things, if in fact the findings are that the current drug supply presents a national security risk, and that triggers the tariff conversation, how do you reconcile sectoral tariffs versus market-based or country tariffs? So if you have an agreement with India, but you are actually going to tariff all pharmaceuticals, how is that going to get reconciled?
And Sarah, we'll close with you just real quick. Thank you.
Yes, no, we need to take some action now. And I think all of the stakeholders and all their trade groups, we need to get together and hammer out a solution.
Great. Thank you so much. Really appreciate it, everyone.
All right, we are transitioning to our next session, fireside chat virtually with me and Governor Moore. While Governor Moore is getting connected, I just wanted to thank the last panel. You might think that, well, generic drugs, drug shortages are a little bit of a change of pace from healthcare transformation, but as I hope the last panel made clear, number one, this is a critical part of our prescription drug supply, and number two, it is also an opportunity for some bipartisan action, building on efforts that are underway between a wide range of stakeholders in the medical innovation sector and the prescription drug manufacturing sector. And it's also a trade issue as well. This came up in some of the discussion that Dr. Oz mentioned earlier, the president's executive order yesterday. Back in my time in government, people may not remember, but there was a similar effort to try to address issues of drug pricing, the differences in drug prices and support for innovation across the country and across the world with an explicit Bush administration policy trying to focus on differential levels of drug payment based on the level of income of different countries, maybe several tiered approaches. That played into the trade reform efforts then. Can't say it got that far, but it seems like there's some opportunities now, both to think about some of the goals intended with tariff policies, as well as maybe ways to refine those goals and synergize with other efforts in healthcare reforms like the ones that we've been talking about today. So I think that's an important point to make. As also you can see, I'm trying to give us a little bit of time to get Governor Moore on screen with us. He has, for those of you watching the national news, there have been some incidents up in Maryland that affected, I think, some of you getting here today as well. The governor has been part of a statewide effort that many of you all know about in Maryland. It's a distinct state for having this kind of all-payer payment arrangement, but it's a payment arrangement that, like a lot of the rest of healthcare that we've talked about, is evolving from one that focused on, setting the rates and trying to keep costs down that way, to recognizing that without moving to keeping a focus on whole person care, overall total cost of care, global budgets, it's very hard for healthcare to keep up with the changing opportunities in technology that we've talked about all day today, as well as the unmet needs for many key parts of our populations. His health secretary, who's also, for those of you who are with us in person here today in DC, is with us today. Dr. Meena Seshamani was the director of the Center for Medicare in CMS during the previous administration, and moved from there recently to take up the challenges in Maryland. And one of the things that we're hopefully builds out of the earlier session with Steph Carlton and others that Rob Saunders moderated, is that we want to explore today these opportunities for synergies between federal and state level reforms in states that are red, blue, and in between as well. So just checking on how we almost there. 30 seconds. Okay. There any questions? I can't tap dance, but and I should say too, I really appreciate you all in the room sticking with us. It's been a while since a break, but we do have one coming up after our session with Governor Moore. And for those of you who are here in the room, there is a reception to follow this event. So please try to build that into your schedule. Will be a good chance to interact. I'm looking around the room, see a lot of colleagues from CMS here today. It's great to see how much the whole agency is involved in the kind of reform efforts that we're talking about today. So maybe a good chance to talk further with some of them as well. And I see Luke doing the sign. He's like, almost there. Let's see, any questions I can answer? No, we'll be getting started in just a moment. I know the governor's had a really busy schedule today, and I know he really wanted to talk with this group about his perspectives on reform. And as I mentioned, the lessons that we're hearing about and learning from Maryland have been terrific. Governor, I was just talking about you. Is Mark McClellan down in Washington, D.C. We are really sorry.
Hey, Mark.
We're sorry you're not with us here in person. We know how busy of a day it is up in Maryland for you, but Governor, it's good to see you again. Thanks for joining us. Any comments you'd like to kick us off with?
Well, first, and again, my deepest apologies for not being able to be there in person. We're actually just completing a bill signing here in Maryland, where I was pleased to be able to sign dozens of bills that are working on the protection of first responders and the environment and a collection of other things. So I'm very, very humbled to be here, but also just really excited to talk about this issue. And so first, again, thank you for having me. And thank you for allowing me to be part of this conversation. So I'm very, very grateful because, not just the quality and the depth of experience that's represented in this room, but also because for so many people in this room, you have been crucial. You've been crucial to Maryland's growth. You've been crucial to Maryland's development. You've helped set the standard for how we are leading in this moment and the things that we want to be able to get done and how we want to be able to support other states in our country. But also, I say thank you from a very deeply personal place for this, because my passion for making sure that we get healthcare right does come from a very personal place. And it's because one of my earliest memories was when I watched my father die in front of me when I was only 3 years old, because he didn't get the healthcare that he needed. He had a rare but a very curable virus that got misdiagnosed, and he passed away when he really could have been saved. And so I've seen so many of these system breakdowns up close. And one of the reasons that I wanted to enter into public service was because I wanted to fight for people like my mom, who instantaneously became a widowed, immigrant single mother who is now going to raise 3 children on her own. That I wanted to become a public servant for people like my dad, who was seeking help and just didn't get the help that he needed. And so I wanted to make sure that we could spend our time helping to connect more Marylanders with accessible and affordable and quality healthcare, no matter their background, no matter their zip code, and to say that we can do that and also still be amazingly efficient with taxpayer dollars. And that's why I think, the Maryland model is a phrase that's kind of been synonymous with this idea of excellence and accessibility since the 1970s, where we do have a unique all-payer system that's really helped to both slow growth in hospital costs, to ensure better patient outcomes, and also save Maryland and the federal government tens of billions of dollars in healthcare. Because I don't think that we have to choose between making sure people get quality healthcare and making sure that we can save people money. And so under our administration, we just made it a core priority that we want to be able to work in partnership with our federal partners to be able to continue that work. That, here in Maryland, we're never satisfied with the status quo. We always want to make new strides. We always want healthcare that's cheaper. We always want healthcare that's more accessible. We always want to make healthcare more impactful. And we always want to make sure we create a society that, as I learned when I was 17 years old and I joined the Army, where we leave no one behind. And so I'm so thankful for this conversation. And again, having me here means the world to me. So just thank you very much.
Well, again, great to have you with us and great to hear your personal commitment. I know how heartfelt it is to making healthcare better. Before we dive into the Maryland model and where it's headed in a little bit more detail, Governor, I'm wondering if you could just talk a little bit of big picture about where you think we are in terms of healthcare reform and health. This is I need to tell you, it's a pretty contentious time in the nation and political differences. There's legislation being debated on the Hill right now that I know you are not in favor of. You've been outspoken in particular areas against some administration policies, tariffs, moving the FBI headquarters. But it does seem like a lot of what you just said sounds a lot like what we heard just a little while ago from Mehmet Oz and some of his CMS team. And I've heard you talk eloquently in other contexts about how, it's kind of the same motivation, I think, behind MAHA in some ways, that our institutions in many areas, and healthcare in particular, just don't seem to be getting it done for some of the people who really are struggling with high healthcare costs and access, despite better drugs and technology than ever before, despite a lot of healthcare coverage. Do we have a chance of making bipartisan progress here?
I do, because also I think that there has to be bipartisan blame, right? I think that the things that haven't worked haven't belonged to a party. They haven't belonged to an administration. I think that, so yes, I've been critical of certain aspects of this administration, absolutely. But my criticism is not based on a fidelity to a party line. I just want the best thing for my people. I just want the best things for Marylanders. And I'm eager to work with anybody who wants to work with me towards that goal. Because right now we need to make sure that we're focusing actually on moving the needle on people's health. We want to make sure we're delivering stronger results. We want to make sure that we're delivering better outcomes, and we want to make sure we're being good stewards of taxpayer dollars. And I don't think that is a party sentiment. I don't think that is a goal of one group and not the goal of another group. And I'm really excited to have the chance to work with anybody who is going to help us to get there, because I think what's going to be needed for us to get there is to be able to make sure we have everyone at the table. And so, I think when we're talking about kind of what are the North Stars that we have laid out, it's, how are we thinking about investing in primary care? How are we making sure we're getting to continue to get people insured? Because, if you can invest in primary care, you're going to do a great job of being able to control costs later on in the future. If you can have more people who are getting insured, you're going to do a much better job of controlling costs when the inevitable happens, and you will have people who will get sick. But we have a better chance of being able to both treat them and a better chance of making sure that that does not have to be something that is completely catastrophic, not just for them and their family, but also for our entire system. And so the work that we're going to do together in this moment, regardless of administration, is just going to have far-reaching consequences, because there is a uniqueness to the Maryland model that we're proud of. But we also know that there's a bigger point that it's making, is that when Marylanders are healthy, it's more likely they'll get a good paying job. It's more likely they'll build a strong career. It's more likely that they won't miss school. It's most likely that they won't take a strain on our public health workforce or our caregivers, which is then going to drive them out of the workforce. And so I really do have hope that we are going to be able to find common ground with this new administration, with other states, to be able to making sure that we can show that this model works. And I think Maryland has a unique chance to being able to continue not just setting a really powerful example, but showing what does success at scale actually look like. And I think we have a real opportunity to get this right.
Governor, you talked about the Maryland model and the unique model, but it is changing. So the model itself has been around since the 1970s, meaning all of the payers are involved in the same structure. It's been, though, kind of a fee-for-service model where you set the rates, and that's changed over time. In the last few years, it's moved to global budgets or caps for hospitals. Now you're trying to take it in the direction of total cost of care and, as you emphasized just a minute ago, outcomes, accountability for results. Can you talk a bit more about where you are in this transition process, what you're looking for, what's coming up?
Yeah, it's really interesting, because I think if I had to, because you are right where that model used to be and what it was known for, but the vision that I know I have and our team has, that if you asked me, so what is the vision for what you would say the unique Maryland approach is known for? I would actually say it's one word: it's innovation, right? That if you looked at any chapter of the story of Maryland's healthcare model, you would see that theme time and time again, that Maryland was kind of, unafraid to be on the cutting edge. Maryland was unafraid to kind of, show folks that, hey, we can actually help to de-risk some of the things that we're talking about and show that there is a real level of innovation. And so I just want, for the time that we're in right now, for Maryland to be able to continue to lead in that way, where, you're absolutely right. I mean, it's as early as the 1970s and 80s that we saw how the Medicare waiver kind of helped to lead a new type of model. You saw how in I believe 2013, how you had an all-payer model that helped us to lead this way. You saw how by 2019, you had the total cost of care. But the thread between all of those things was innovation, right? That was the thread between whether you're talking about the Medicare waiver, the all-payer, the total cost of care. It was innovation. And I think that that's exactly how we want to be able to lead inside this moment. And I know it's going to be imperative for us to be able to get that right, because you have a whole series of things that, frankly, that we're doing in Maryland that I think are tremendously innovative, but that are relying on making sure that we have a healthcare system that can both move fast, that can make sure we cover down on individuals and also be proactive and make sure that we're saving costs. Where when I came on board, we said we were going to end child poverty in the state of Maryland because we know the impacts of child poverty. And we know it is just so deeply unfair, and no society can call themselves civilized, if you have children who are growing up and are literally their futures are being determined before they even have a say. So we said we're going to have have an aggressive bipartisan frontal assault on child poverty in our state, that we pass initiatives like the Enough Act and the Enough Initiative, which focus on ending child poverty with a focus on improving health in our neighborhoods, that we are investing in partnerships where we just announced an agreement with a nonprofit Serum, which is helping to make prescription drugs more affordable for Marylanders, right? That we invested in rural healthcare. When many states are leaning away from rural healthcare, Maryland's actually leaning in. And late last year, we broke ground on a new hospital in the Eastern Shore, one of the rural parts of our state. And so all these are things that we're really excited about, that Maryland's having a unique leadership role in. But we also know that quality healthcare, being creative and innovative, making sure that Marylanders can get top-notch care, that's a prerequisite in order for all of our other goals to be successful.
Governor, I want to stick with your innovation theme. So Dr. Oz spoke earlier about innovation to improve health. Then we heard from the head of the Innovation Center at CMS, Abe Sutton, talking about their new strategy just announced today. And as a part of that, we touched on the AHEAD model. That's the multi-payer aligned approach to trying to drive innovation around total cost of care and health outcomes, and that is continuing to be a part of the Innovation Center portfolio. So I just want to do a little innovation check on a few areas, from what we heard earlier to your take on the situation and the path forward in Maryland. Probably the biggest single theme that the new CMS team has emphasized is what they're calling evidence-based prevention. And that does mean preventive care, and we can talk about that too, but I want to go to some of those other kinds of barriers to good health that you talked about and that we've heard a lot about already today from other perspectives, the non-medical factors that so often get in the way of good health. That can be nutrition, can be housing issues, can be other issues like that. How do those prevention, evidence-based prevention steps fit into your strategy? We're trying to improve health without increasing costs. Are these effective ways to do it? And what's the experience and your next steps there?
Yeah, I'm really encouraged by what we heard from Abe and Dr. Osmus, because I think it's completely consistent with where we are in Maryland. That how do we think about addressing these non-medical drivers of poor health? Because the truth is that if I can tell you what the healthcare challenges you are going to face in the future, I can tell you the healthcare costs that you're going to face in the future if you tell me the non-medical things that are going on in your community. Talk to me about nutrition. Talk to me about housing. Talking about lifestyle risk factors, right? Especially what we're seeing in less resourced populations. If you show me those data inputs, I can tell you what your costs are going to be. And the communities that are able to help to address non-medical drivers of poor health are the ones that are going to be able to help control costs later on. Right. So I think there's a deep level of consistency. And I know that, before I ran for public office, I ran an organization called the Robin Hood Foundation, which is one of the nation's largest poverty fighting organizations, where about 40% of our budget every single year. And during my time as CEO, I think we allocated over, $650, $700 million during my time as CEO. And I would say 35, 40% of allocation went towards issues of healthcare in some way, shape, or form, right? And I knew that when I was coming in as Maryland's governor, where I'm very proud of every segment of my state, but I'm also very clear, I'm a Baltimorean, right? That's where I'm from, and it's not lost on me that in 2020, 1 in 5 of our children was growing up with asthma. 1 in 5. And that's not because our children who were born in Baltimore just had bad lungs, right? It's air quality. It's what they're being asked to breathe every single day. And it's the reason that we knew, I came into this role knowing that poverty, when people say, how does poverty show itself? It's like every way. It shows itself in the water that people drink, in the air that people breathe, in the transportation assets they have or don't have, in the way they're policed, in the schools that they attend, right? In the housing that they live in. It's this constant reminder of inequity, right? That's what we see. And so I think that what we tried to do, and why I think it's wonderful to hear the new administration saying this is going to be their role in it, because I really do believe if you want a test case of where we can show where a symbiotic relation looks like, look at what we're doing in Maryland, where in our administration, like we have taken aim at looking at these underlying challenges that our communities are facing, particularly communities in poverty. And then because we know that those are the things that lead to poor health outcomes. It's the reason we launched things like what we call our Sunbucks program, which helped feed over 500,000 children over the summer. It's why we launched a new online service to help Marylanders check their eligibility for food assistance. It's the reason that we've done so much investment when it comes to things like broadband access, so we can help to enforce things like our telehealth platforms. It's the reason we're working with our farmers and our watermen in Western Maryland and the Eastern Shore to help to keep our community food pantries stocked, right? So I believe deeply that this doesn't have to be an either or conversation, that we will continue to focus on both health coverage and primary care, but we are looking upstream of medical services to try to focus on just building healthier communities, because I do think that's what's going to help us in the long term as well.
And you talked about your emphasis on primary care already as well, and integrating that in addressing the non-medical drivers effectively. One other theme that the CMS leadership and the Innovation Center are stressing is just making healthcare simpler, reducing the administrative burden, the paperwork burden on healthcare providers. I know in Maryland, you have a collaborative effort involving health plans, involving provider groups, hospitals, other stakeholders to try to take further steps together to maybe align on what works, reduce those burdens. It's awfully hard to do at a state level alone. We depend on national standards for insurance claims and health data records. Could you talk a little bit about how that emphasis from the new administration might fit with where you're headed in healthcare reform in Maryland?
I mean, listen, I really appreciate the focus on this, because I look at some of the systems that our nation has in place, and it's not that they don't work. It's they're not built to work, right? If these were systems that were built to work and just not working, that's one thing. But I don't think that many of these systems are even built to work. And that's actually in many ways the more heartbreaking thing about this. And so it's why in Maryland, why I think we have really tried to lead the nation, not just on healthcare applications, but really about healthcare solutions, by starting off with what is the end goal that you're actually looking for, and then building the solutions based on the end goal and not kind of the other way around, which is actually going to, and I think one of the big takeaways that we've gotten is the importance of bringing all players to the table to make sure we're really building bridges across the public sector and the private sector, making sure you have your nonprofit partners on board, your community-based organizations, the community themselves, who are helping to tell you what would work in our community and what would not work in our community. And that's why we're such big believers in this idea also of just place-based strategies. Because if you do not incorporate community into that work, you will have organ rejection, and people will not feel like this was built for them because it wasn't built by them, and they had no input as to what this thing was actually going to look like. So I think the Maryland model really provides a strong pilot environment for showing how we can bring down administrative costs. I think that the Maryland model really helps to show that this idea that you can that it's going to end up costing everyone more to provide better care. I think in Maryland, it's kind of showing that that's actually not true. And it's actually a false choice that we're making people make on this one. And I think one of the best ways the states can really save on administrative costs is by looking at what Maryland is doing. And on the things that I know we're really excited to be able to, again, hear some of the directions that we've heard from the administration, but I think really to be able to continue being their partner, because I think Maryland can actually tell a pretty amazing story about what we can get done together.
That does sound like a great pilot opportunity for these next bold steps on technology and supports to get these burdens out. One more I wanted to touch with you on prescription drug costs and transformative therapies, treatments that can not only slow down chronic diseases, but maybe even eliminate them. Gene therapy, so a new innovation center initiative moving forward with states on alternative, maybe better ways of paying for gene therapies based on outcomes. Again, moving that focus on outcomes. Any comments on that and Maryland's strategy for those transformative therapies?
Yes, this is another thing that I think is very welcoming for us, because I think one of the big and unnecessary challenges that we have continued to see is just the cost, and in many ways unnecessary costs that we continue watching Marylanders have to face when it comes to prescription drugs. And it's, and I tell you, I was really encouraged when I heard, of the recent intention of the administration of saying we want to be able to drive down healthcare costs, because to them, I would say, hear, hear, because that's exactly what we want to be able to do in the state of Maryland. And we really do look forward to working with them to be able to come up, what is the best way of doing it? What's the smartest way of doing it? What's the most sustainable way of doing it? Because I do think there are different models and different platforms that I think can make sense. I know the administration talked about the most favored nation status on the way they're helping to address healthcare costs. I think that some other things that we also should be looking at is the kind of work that we can do in partnership with some of our nonprofit partners as well. I mentioned before the partnership that Maryland has with Serum to make prescription drugs more affordable. And this is a really interesting model, because it's basically saying we're talking about prescription drugs that essentially would be disposed of, but still work very effectively to be able to support people with the illnesses or the conditions that they might be dealing with. But now it's being done at a fraction of a cost. And so I think being able to work in collaboration with our federal partners of bringing down prescription drug costs, of being able to be innovative and thoughtful about making sure that the only people that can get specialized care should not just be the ones who can afford it. That's not a fair system. It's not a fair model. That we need to make sure that care is something that should be a human right for our folks, and that we should not allow people to sit sick, and frankly, sick in a very expensive fashion for the rest of our population, when we know there's things that we can do. We know there's innovations we can put forward, and we can actually work together to be able to get things done. So again, I thought the announcement was, I thought the direction that they want to go in was really hopeful and really promising. And I just want to, make sure that also there's clarity that Maryland really looks forward to being a partner in that work.
Well, I know we've gone through a lot of goals here that seem aligned. It's always hard work, though, from getting from the goals to actually implementing together. We've just got about a minute or so left. I got to say, one of the things I've always been impressed with you, and frankly, working with your staff, Dr. Seshamani, your chief of staff, others, is the optimism that you all, they're great, but they also keep some optimism despite, you've been through so much in your own life. Any final words for this group about there is some hard work ahead to get from the goals to the implementation? Any final words of advice for how we can take that on together?
Yeah, I don't know. I've been really blessed, because I also believe that the team who I have around me are just the best in the business. People who are hard driving and smart, and who are really mission driven. And that's the thing I would say, for this group is, these are complicated times. And we are seeing every single day, and we're hearing from our folks every single day that getting the basics seems to be more challenging than ever before. That costs do seem to be completely outstretching where incomes are. That we're watching more and more people who are now just more food insecure, housing insecure, job insecure. And we get it. But I think the thing that always gives us a real sense of hope and optimism is for all of us and for all of you in the room, is what a blessing it is to be in a position to do something about it, isn't it? Like, I mean, when history is really being made, that we have a chance to be at the table. We have a chance to really be innovative and to really be thoughtful and to push hard. And, you know, I have a clock that sits on my desk right here. And it says, you know, how many days left that I have in my first term. And the number's now at 616. 616 days left. Now I'll run for re-election next year, so I plan on re-upping the number again. But 616 days left, and I kind of go into it where I think for each and every one of us, and each and every one of you who are there, the only guarantee I can give you is that someone will sit in your seat at some point, right? I'm the 63rd governor of Maryland. There will be a 64th. There'll be a 65th. There'll be a 66th, right? That's the guarantee we have. So the thing I want to do is I've got 616 days left to make sure that I make the most of what the 63rd governor of Maryland can do, right? And I just think that while these might be challenging and difficult times, I just think we've seen challenging and difficult times before. And we've learned that we know how to do hard things. And now it's just going to be one of those moments where we're going to have to do hard things. And it's okay, because we will, if we do the hard things, we're going to create a society that that those who came before us hope for, and create a society that those who come after us that they deserve. And that's why we wake up every morning with a core focus on making the day count.
Well, thank you for making this half hour together count. That's on top of signing 18 bills, and I know you got a lot more to go on to do, but really appreciate your time and effort with us and your commitment to fundamental and effective healthcare reform. A great opportunity today, big challenges, but really appreciate your leadership, Governor. Thanks for joining us.
God bless, Mark. I appreciate yours. Thanks, everybody.
All right, I'm Marianne Hamilton-Lopez, Senior Research Director at Duke-Margolis. It is my pleasure to start the first of a two-part series where we start to think about what is the role of the private sector and philanthropy and kind of helping us to make positive outcomes in health. So I have the distinct honor of bringing forth my panelists. We have Cindy Escobar Alvarez from the Doris Duke Foundation, and then Tim Lash from the Gary Mary West Foundation. Oh no, we'll just come over here. We're a small group, but we'll go. All right, so we've heard a lot today about new policies from CMS, new directions in CMMI, maybe a focus on chronic care, really trying to address costs. There seems to be a lot of changes and kind of some policy directions, but you all in the world of philanthropy, especially with your two foundations, have also had some differences in how you have approached philanthropy over the last few years. They used to think maybe that we could just fund research and that would be the end of it. But I think we're seeing some efforts that are broader in scope. So maybe starting with you, Tim, can you just talk about most recently how your philanthropy and your approach to giving has changed in the last few years?
Sure.
And why?
Sure, no, happy to, and it's great to be here. And first off, look, the cheese has moved, right? And I think there's two things that have driven that, right? You know, historically, healthcare has been very slow to change, and that's a function of just entrenched positions and profit motives, and policy can be, I think, relatively slow as well. And certainly, I think just over the past year, and certainly with this new administration, we've seen a willingness to move off of the status quo. And with that volatility, even some turbulence, there's incredible opportunity. And so I think that has caused us to reconsider some of our positions. I think the second thing that has changed is there has often been a very wide gap between the stories we tell and the lives we live. And what I mean by that is the perception versus reality. The US healthcare system delivers today the worst outcomes versus any developed nation across the board, full stop, right? But historically, people believe we have the best healthcare. And that gap between perception and reality is closed, and they are voters, right? And so we are, I think, in a historic time, right? And so from a perspective of West Health, what hasn't changed is we really believe that everything has to be grounded in the lived experience, whether that's in understanding the perceptions and reality as reported by individuals and families through our partnership with Gallup, which is a world leader in data and analytics, or in our analyses of outcomes and payment and clinical conditions, right? We believe that that's so important. We actually have invested several $1 million in developing a platform we call Mosaic, because we really do need to understand the intersection of all of these things. And so that is the core. We can get into the details, but when we think about where we're focused on more structural areas now, right? So addressing market failures, both on the drug side and where consolidation occurs across the healthcare system. We have negative outcomes for individuals. I think we're very focused on, ensuring that we have the evidentiary underpinnings, right? Around scalable models that can inform policy. And then finally, through our partnership with Duke and others, policy really are the bumpers or the guardrails, right? That will drive the change that are needed. And that's the third area that we're investing heavily in.
That's great. Thank you. Cindy? Well, we're coming at this from a very, very different perspective. And, the Doris Duke Foundation, and first of all, to say thank you for having us, giving us the opportunity to share why Doris Duke is interested in learning more, as well as the collective of funders with which we work. So we're really, as you mentioned, we keep on hearing these statements, right, of we spend so much as a country in health and so much in research, and Americans' health is not getting better at the same pace, right? And at the Doris Duke Foundation, we have a long-standing, we have a long time supported clinical research, and really looking more at how to deal with disease, what new treatments to come up with, right? We're invested a lot in the fundamental understandings that help us get to therapies and treatments, but also in our years of supporting clinical research, have come to appreciate that there are different forms of knowledge in the continuum from understanding humans as from a molecular perspective and disease from a molecular perspective, all the way to populations, and that not all of the research forms along that continuum are receiving the same level of attention that could help us improve health overall, right? And so that really got us to this point, which is we thought it was an important moment to try to identify, and this started actually a couple of years ago now, or at least a year ago now, to try to understand what are the opportunities, what is the knowledge, and what are the important research questions that need to be addressed with more intended resources than we have in the past, not just Doris Duke, but as the philanthropic sector. And that with the same level of rigor and attention that we have brought to trying to understand molecular basis of disease, what are all these questions in policy? What is that knowledge base that can help further health?
So can you go into that process a little more? So we've talked to other foundations who have made that shift, perhaps just a focus on maybe basic research, but they are maybe through what they're seeing around them in the world, or maybe from the direction of their board, or so many different reasons for making that shift. But sometimes we've heard, where do we even start? If we're going to start taking on every policy and really want to be able to address all of these various issues, how do we make that shift in our foundation in a way that is meaningful?
sure happy to touch more on that. So I think so. We approach this with humility, and as scientists, we are. I will not name. I encourage you to look up the collective, the collective with whom we're working, and maybe we can distribute that information later. But it's 10 different nonprofit funders of health research, most of which have funded most of biomedical research. But I think we started with humility of asking, and a scientist asking the question, what do we know, and where can we learn more, right? And so we supported, this meeting today is one of 18 conversations that we have supported nationwide. And each one has a different focus, right? This one is a focus on healthcare and health policy. Last week we had some on learning health systems, and it's very interesting to see how it all falls together. But we are really hoping that we will document all the learnings from these 18 conversations nationwide to distill three things, right? First is, what are those really important questions where there's room for innovation, where philanthropy can be catalytic in promoting that generation of that knowledge. The second is what is sort of the analogous pipeline of taking these knowledge from creation to application, right? In drug development, I think that even if as a scientist you're not involved in the drug development process, you know how to generate that knowledge early on, so that it fits into that pipeline, right? So what is the analogy here? And maybe we can talk more. You can show your what you've learned from the space in supporting these areas of research. But also the third one is who are the players in this space, right? And how do each contribute uniquely to solving eventually the solutions to improve health.
So if we could, just with that question of who are the players, one thing that's, we've had some discussions before this conference, and something that you both individually brought up is that it seems like philanthropy or the private sector or any areas of giving are kind of at a crossroads because our environment is changing. We have different levels of federal resources, and perhaps more of an expectation that foundations or philanthropy will fill some of those gaps. Sure. So I think the question that you both posed back to me that I'd like us to delve into is, do we just fill the gap? Do we fill a gap where maybe their federal resources were there before? Or do we think differently about how to give or where to give? So what is, how would you address that?
Sure, I guess I'll start. I mean, I guess my response would be, do we want more of the same? And can we afford more of the same, both in terms of the cost and the outcome? And I think the answer to that is absolutely not, right? And so philanthropy or foundations have historically, played a role on taking on risk where perhaps the private sector or public sector either couldn't move fast enough or, prioritize longer term goals versus, near term EPS, outlook, et cetera, right? And I think that has changed considerably, right? And so we're sitting in a place where, there's been some reshuffling, right? And there are certainly gaps, and we're getting knocks on the door of like, you need to fill the gap. And I think that's a fool's errand, right? I mean, to do more of that, right? There are for sure areas in research and, in health delivery where there might be gaps that, appropriately need to be filled. But I think we need to look, quite specifically at, where do we want to go moving forward? Where are the goals, right? And then, where is that capital that's deployed? And for us, as we look at that, it's around addressing some of these more structural areas. And the final point that I put on that is, I don't think it's just, that when you talk about the players, I don't think it's just foundations and nonprofits anymore. We have, forward-looking, entities like Aon, and Greg Case is their CEO, who is really leading at the business side, the discussion around GLP-1s or GLP drugs. You have, entities entities like Intermountain Healthcare, which is, heavily investing in rural health and the connection of data and transparency and how we can liberate that to make more informed, decisions within our health system. And so I think we have to look at how we make, stronger connections between the private sector, both nonprofit and for-profit entities, and the public sector if we're going to navigate this. But just, filling in gaps and saying like my lab lost, $10 million, and so we need to fund more of that. I don't think that's going to move us off of where we've been, and it's certainly not going to, make families and individuals healthy.
Yeah, right. I agree with you that this would be major gaps. So I think we it all what brought us here today, right? It all started there, and we saw this major gap in how nationally we are supporting health research, right? And especially the forms of research that are not receiving as much attention and resources. And one of the goals of in addition to elevating knowledge of supporting this series of meetings was to elevate the importance of the research and to try to bring attention to the importance of the information that is still needed to further health and additional resources. We saw that opportunity. So that remains very much still a big gap, right? And in this moment is, I think, more evident.
Well, how can you explain, as you're trying to navigate a new environment and where people might be coming forward and say, filling this gap, but you're saying we want to do something new, we want to do something better. Where are those conversations happening? Is there a way that and you're saying we need to start understanding how the stakeholders can work together and perhaps be more coordinated, private, nonprofit funders. How do we get there in those having, and especially if there's going to be more eyes on the private and foundations as we move forward?
Yeah, so I think you have to be clear on what you're looking for, right? And so when I think about, the opportunities and how to accelerate, and deliver against the goals that were outlined by Dr. Oz, right? Part of it is like we need to redistribute where we're spending money, right? And I think that means specifically within health systems, I think we need to have a greater high reliability of care. So reducing variation around the mean and driving that mean in a more positive direction, right? Because if you don't do that, regardless of what payment models or risk you have, right, it's going to hit a delivery system that's fundamentally shattered, right? And then I also think we need to look at greater integration, things like behavioral health and physical health, and how do they come together? Like that's an imperative, right? And so being clear when you're talking to stakeholders, right, on what we're playing for, right, structurally, I think is absolutely critical. And then the other piece of it is we have to get out of this echo chamber, right? We work in the intersection of healthcare and aging, and aging is more of an echo chamber than healthcare is, but it's a lot of health people talking to health people, and I think Dr. Oz gave a great example, right, of his history in sports. We were recently down in North Carolina engaging with owners of some of the largest sports enterprises, right, in the world, right? Why? Because they get it, not only for the franchises they run, but they see how the lessons learned from what they've done with their athletes and those learnings translate right into things that have to be, engage, more engagement, within the community. And so I think it's those two things: be clear what you're playing for, right? And then also you got to get out of the echo chamber of, where we've historically looked for partnerships and go after the non-traditional connections that I think could be transformational.
Yeah, I mean, I think the conversations are happening in places like this one, right? And I encourage you to follow the additional 17 ones that are happening and making those connections. I think this is a moment where philanthropy, one of the things that we can do is get people together who might not otherwise be talking to each other, and I see that as something that we'll continue to do. And because at the end of the day, you're all the experts, right? I was sitting also with a colleague, and we're commenting on how some of these are difficult problems that have been facing the field, right, for a long time. And so so really it's just getting together that we can continue to really see, and in a moment of need, how do we think differently about going about those problems, right? And because you never know who might have a solution, right? So there's so many new ideas coming up, new generations of scientists as well.
Great. Tim, if you wouldn't mind, you've, as in your kind of your expanded scope, have really thought a lot about new areas, and you already talked about, kind of the intersection you play with health and aging. So you do a lot of work in brain health. Really interested in kind of rapid learning and how we can advance care in that way. How do you, as a foundation, as a part of a larger community, define your priorities and decide where you want to put your efforts moving forward? And where do you see kind of the future of where you'd like to see health policy move forward from your perspective?
Yeah, so look, I think timing really matters, right? And so, the biggest lever we have, right, is federal policy followed by state policy. And so you need to understand, first and foremost, where is that strategic direction and what are those goals? And you need to align with them. Right, full stop, right? Because otherwise you're trying to swim upstream, right? And so we spend a lot of time, understanding those pieces, and then I think you need to understand where are there areas where there's the greatest underinvestment, right, and the greatest need, right? And then the final layer that we put on top of that is there something that's actionable, right? I mean, you can identify areas where there's need, and caregiving, I think, is a great example. I mean, the amount spent on informal caregiving in this country, right, is enormous. Sitting here today, there are not great solutions on the table, right? Vis-a-vis opportunities at transforming, like how care is delivered or integrated for things like mental health or other conditions of brain. And I think, a great example of how to, think through of how you need to, sort of along the entire continuum, is within brain health. And I think Alzheimer's is a great example of that, right? And so if you believed the market forecasts for the original disease-modifying drugs or the ones that we have today, which, by the way, I don't believe, and I'm not an expert on Alzheimer's, but engage with many who are, right? These drugs have some promise in terms of the possibility of something, but they're not the answer today, and they're fabulously expensive, right? And so as we think through that, even if, right, like they were the holy grail, right, for Alzheimer's, we don't have a delivery system that can screen, diagnose, and otherwise disposition in terms of treatment at scale, right, for the number of families and individuals that are affected, right? And so you have to think about not only the drug development side of it, but you have to think about how is that received from the system side of it, right? And then what does that mean in terms of the overall healthcare spend, which is where the policy side comes into it, right? And I am hopeful, right, that GLP-1 drugs might be, that intervention, not just for obesity and diabetes, but something that, in terms of primary prevention, can have a huge impact on brain health. But we can't afford 24 months, right? In many states and geographies, in terms of screening and diagnosis, et cetera. We have to think about a primary care system that is scaled and prepared, right, to be able to, address the patients as they're presenting in a responsible way, not as, and it might be well-intended, but not as, when pharma comes in and says like, well, we need, to open the pipelines now, and so let's rejigger it. I think we need to get ahead of that, but we also need payment models, and this is something we're working with the Duke team on how do we pay for these drugs, right, in a responsible way that, allows us to get the benefit, right, but not bankrupt the system as we're doing so. And so it really is, thinking through, the broader intersection or interdigitation, right, of these various components that I think the answer lies in.
Well, I think that's very helpful to kind of think of it as kind of you're aligning with the larger ecosystem. You're trying to see where there are some needs that still need to be addressed, and also where you can take action. To me, you're talking about how you work within one foundation, but you're also part of a group of 10 others. Do you follow a similar process? And then kind of what is your long-term approach and what your goal is at the end of that?
Yeah, no, that's a good question. And, something that I like to start with also is to what is our mission, right? And the Duke Foundation, is building a more creative, equitable, and sustainable futures. There's supports for arts and culture, nature, health, and well-being. And so that's what guides us, which is based on Doris Duke's will and her wishes state this that were stated there, broadly representing those areas. And just like Doris Duke, each one of the 10 members of the collective have their own mission and goals, right, and go about the work a little bit differently. We are synergizing on learning. We all want to learn more about these. And what we are hoping is that from all these conversations, we will have really a good view on at least what is all the exciting work that is happening in this space, and where each of us sees there is room for the future, right?
I know we are down to our last 38 seconds, but I think what's important here is that what you all have kept saying is that you bring different stakeholders together that might not be speaking currently, or you're doing things differently than maybe the federal government and their giving have done in the past, or their support. So how can we as a community make sure that foundations, philanthropy is at the table for these policy discussions?
I think if you don't see them there, you have to ask why, right? And we're at a historic moment, I think, in healthcare to drive change, right? There's a lot of motivated actors, right? That have a lot to lose and a lot to gain, right? As we sort of navigate this moving forward. And I think we don't just need philanthropists there. I think you need 360-degree representation from those that are affected and those that have expertise, right? If we're going to navigate a stable path forward.
Great, thank you.
Well, I'm so glad you asked that question, because I think often, we are philanthropists, so people think of us as funders, right? And I think there are many roles and many ways in which we can be helpful, such as elevating the importance of a field. They're contributing to forging pathways for more support, right? Philanthropy is small compared to other, like the role of government, for example. And so we can help facilitate those pathways for support.
Great. Well, please welcome, join me in thanking this panel.
Oh, Chair Greer. Come on up. I'm going to take that from you. Thank you. Good afternoon, everyone. Thanks for the welcome. Really appreciate it. So today we're going to continue this conversation about investing in healthcare. I'm Cheryl Pegas. I co-chair the Duke-Margolis Institute's Capital Impact Council, and you will hear us talk a little bit about that work. It is a new council, and so I'll share a little bit with you about what we do there. What I'd also like to just start off and do is introduce my colleagues. Lisa Suennen, she's the managing partner at American Heart Association Ventures. I think many people know Caroline Pearson. She's the executive director of the Peterson Health Technology Institute. And yes, Greg, many people know you too. Greg Grunberg, who's the head of Life Sciences North America, Temasek. Capital Impact Council, I think we all know, and you've heard a lot about it today, that investing in healthcare, if you just looked at government investing, you just heard a little bit about philanthropy, it gets a lot done, but there's still gaps in the things that we know we need in healthcare. And that is where private investment has always played a role. We talk about private investment, and I think many of you would say, we hear a lot about the financial returns. What you don't always hear about is the health value returns. How are we improving outcomes in a community? How are we supporting innovation for a health system who could not go it on their own, and putting AI in an institution? And so this Capital Impact Council was formed to really ensure that people not only know about the financial returns, but they hear about the health value returns, and we call this health value ROI. This group that has come together, it's about 20 different organizations. Some of them are listed on our website, but it's being led by, of course, the Mark McClellan. I co-chair that with him, and we could not be here without Bob Margolis. Today, we wanted to introduce a little bit about what that work looks like that we're doing, how we're making transparent the case studies of how we invest. Here is what we're measuring. Here's what that looks like, and leaving it open so people could see what we're doing. And Caroline's also going to share with us, how do you look at companies when you're evaluating whether they're really adding value? So I'm going to ask Lisa, starting off to my left, which many of you know Lisa really well. Lisa, for joining the CIC, you're at the American Heart Association. What was your why for saying, yes, this is something we should participate in?
It was actually really easy for me to say yes to this, not the least of which is because you two guys are involved, but are the mics not on? Mics. Check one, check two.
So while we're fixing Lisa's mic.
All right, there we go. So as I was saying, not the least of which is because you and Mark are involved, but it's really easy to say yes because my whole career of investing, which is fairly long at this point, has always been about how you use quality and value levers to create cost savings and thus returns. I mean, I think those things are completely consistent. And, you know, this is in the Heart Association, all of the investment focus is about ensuring that our mission is realized. So for us, even if we're thinking about financial returns, that always comes second to impact and to the mission overall of making a difference, bringing science to life in a way that improves patient experience and provider experience.
And Greg, I'm going to ask you, so you invest differently, and tell the people, everyone a little bit about what you do, how you guys look at it, and why this is important for the way you invest.
Great, thank you. So I work at Temasek. Temasek invests capital globally on behalf of the government of Singapore. I'm privileged to lead the US healthcare and life sciences investment activities. One of the core pillars of Temasek is longer lifespans. So we have a very dedicated effort, of course, aligned with healthcare. And when we look at that and translate that into our practice, we think a lot about the values that we represent in investing in healthcare. So, so that's one part of the equation. The other part of the equation is I had the privilege to go to Duke for medical school and business school. And the reason I went to business school in the middle of medical school is because I realized that the most interesting part of medicine for me was the stuff that needed to get fixed. It could be done better. It could be done differently. I actually convinced someone at Duke to let me write a business plan while I was a student for the Duke Center for Integrative Medicine. And so my career has really been looking for opportunities to connect the medical insights and the business insights. And this wonderful platform at Temasek has allowed me to do that. And this privileged opportunity with the Duke-Margolis Foundation to really think about this core question of how can economic interests and healthcare value truly align is really a core mission statement for what we're trying to do.
And Caroline Peterson comes at it. There's some similarities, some differences in the way you look at it. And I think over the last couple of years in the work that you've been doing, we're really seeing a third-party clear evaluation methodology of what's working. And tell us a little bit about when you do this work, who is it for?
Yeah.
Who's the audience to benefit the most? And then when you look at what you will continue to do, I think we talked earlier just about the new AI paper. Even if there's not evidence, how do you continue to contribute so we're all making informed decisions?
Yeah, thank you. Can you hear me? Yeah. Okay. Well, I think we do the work for all of us, right? I mean, we really are just, we're a philanthropy. Our goal is to get better health outcomes and greater affordability over time. And we believe that technology and innovation is going to be critical to accomplish those goals. We need, we need digital health tools and we need health technology to close our access gaps, to scale our workforce, to improve our health outcomes, and to do so at a way that we can continue to sustain and afford in the future. And COVID was very helpful in accelerating some initial, probably overdue adoption of health technology. But as we saw a lot of purchasers, whether that be health systems, doing more telehealth and other digital tools, whether that be health plans doing a lot of sort of disease management, chronic care management, or employers trying to sort of close access gaps for mental health and other things. Everybody sort of adopted a lot of solutions. We saw a lot of investment in the space, great innovation, but folks were really overwhelmed. So as we have set out to be independently assessing, really on the basis of clinical outcomes and economic impact, not to the companies, but to our healthcare system, we really do that both to get the purchasers to buy better, but with the theory that actually, if the customers care about it, then that drives all of the future of investment and innovation in turn. And so that's how we approach it.
And Lisa, you talked a little bit about you've been doing this for a while. One of the things we know is that there are inconsistent improvements in health value and in investments. Some of that is just because life happens and it's investment. Some it's how did we set it up? When you think of important tools for making sure that a health investment not only looks at a financial return, but clearly is doing something to improve access, parts of the country that need better health care, how do you think of a framework that helps and assists with that?
Yeah, I mean, I think that is the whole art of it, right? Is trying to figure out how you align the incentives. And we think about it in terms of the patient incentive, the payer incentive, the provider incentive. And when you find something that has the potential to align all three of those, you got a potential winner. It's rare that they occur. And that's why you see, in our case, we probably see over 1,000 investment opportunities a year and do, 3. But I'll give you an example. Maybe that's the best way to do it is sleep apnea, an area that is really important in cardiovascular and brain health, 80% undiagnosed, affects 30 million Americans, causes unbelievably high cost conditions downstream, and getting diagnosed is really difficult. So we invested in a company that does a home patch. It's a digital product that's got an app and coaching attached to it around this. It provides a gold standard level diagnosis equal to doing the same thing in a sleep clinic, but you do it at home in your normal setting, which is actually more conducive to better diagnostics. And it can be done longitudinally over time, because if you go to a sleep clinic and one night you don't have an apnea episode, well, that was a waste of a lot of money, probably thousands of dollars, whereas it can be done at home for a couple $100. So it allows you to reach more people. It allows you to get the top quality outcome from a diagnostic standpoint, and also add some monitoring and coaching to it to help patients more actively address their condition, give them information, and it creates savings. So it's sort of a winner for everybody, if you think about it. So both from treating a condition, but also the prevention of the stroke that often comes with, undiagnosed sleep apnea.
And Caroline, if this company came to Peterson,
oh gosh,
how would we?
How would you look at it? Because I think that's so. We set up the Capital Impact Council because we know one of the things we want to do is not just self-report, but be able to use tools that are validated, following the evidence-based guidelines, so that we are helping a company evaluate, helping investors get better at choosing investment and using an independent source. And you're doing that now, I'd say, for purchasers. One of the things we want to ensure, right, we always hear that they're bad actors in private investment. Okay, how do we make them better? How do we partner? How do we have tools? How do we be transparent? So if we brought something like this to you, where would you start?
Well, I think, we start with simple questions. We try to say, does it work and is it worth it? Obviously, simple questions are always more complex than they appear. And so, but I think you heard Dr. Oz say, we want to set guardrails and then we want to create competition and let people run within those guardrails. But if you don't know where the end of the race is, right? If everybody's running in a different direction, then actually we don't know who's best. And so part of what we're trying to do in the market is sort of create some of those guardrails. Historically, solutions like the ones you're talking about might have gone to employers or to health systems and said, oh, we have great engagement, we have a really good user experience, the doctors really like reading the data on this one. Maybe it reduces the cost. And so you say, well, what is it that we're trying to assess based on? And at the end of the day, it's healthcare. We want to make people healthier. And so we try to sort of create clarity around just being really stubborn and saying, if it's diabetes, you want to reduce the A1C. If it's sleep apnea, right? Like, what are the right clinical measures on that? And then you can begin to foster evidence generation around those sort of clear endpoints.
Yeah, but I do think it is. I left the guardrail analogy, and then to your point, how do you pick the right horse so that you're staying within the guardrails? And that, I think that's the next step. We've talked a lot about, Greg, just about technology. We've talked a lot about where AI can go. As you look at investing today, are there particular areas that you say, these are the places that we're going to get the best health value ROI and financial ROI? And is there a framework you utilize in the work that you do to say, yes, here's how we should approach it, here's how we should start it, and here's the iterative approach, if you will, that we might take?
Thanks for that question. We think, especially when we think about investing at scale, about the biggest problems in healthcare and those where true outcomes can be moved with a business model, with a technology, with capital. I want to provide a few examples. One is elderly care. We all know that the last years of life can be the most challenging years of life and also the most expensive for the healthcare system. So we asked ourselves, is there a clinical model that can really move the needle on outcomes for the most frail elderly patients in America? And then we asked ourselves, what would be the value associated with different approaches to that exact unmet need? We ended up finding the area of PACE, Programs for All-Inclusive Care of the Elderly. This is a program for dual eligible patients that's approved in many but not all states, that has some regulatory barriers, but had been unlocked for private companies for the first time about a decade ago. That's a company in a category that really, I would say, focuses on a gold standard of care. And think about COVID, the period of time where you really prayed that your elders were at home and not in a nursing home. So you can imagine a care model that delivers on best quality, best outcomes, and reduces cost for the system is where you'd want to hunt as an investor and can do good by society by doing it. But it's not always so easy, right? So, I'm going to give you another example. So the gold standard of care in OCD, obsessive compulsive disorder, is exposure response prevention. Exposure response prevention has been demonstrated to be as good as SSRIs. Approximately 2% of the population has OCD. So one innovative entrepreneur, CEO said, I want to move the needle in this indication. He figured out how to do this model via telehealth. Then he went out to payers. And guess what? Payers said, well, I'm not even sure I have any OCD patients. I'm not sure I want to pay for this. Fast forward 5 years later, the company has now treated thousands and thousands and thousands of patients. They've helped patients who may not have known they had OCD understand that they have OCD. Now payers are coming back to them and saying, we're not paying you enough to take care of these patients. But what's the barrier for a company like this? The company itself that's doing the care delivery doesn't even have the data to measure their own results. So one of the things I really want to highlight here is I've never met a compelling CEO in healthcare that didn't want to make healthcare better. I actually don't know investors who don't want to make healthcare better, but some of the barriers around data transparency, finding that alignment between business model, clinical care, and what gets paid for is very challenging. I think the reason this is such a right moment for healthcare is because we have all the tools, and I think we have the will to start righting these challenges. And so I'm really looking forward to the future of healthcare and also private investing in healthcare.
Yeah, and I think, just the example you just gave, without private investing, that would not have gotten off the ground. And I think that's the importance of the private public partnerships as we do it. Caroline, a lot of health systems are buying AI tools. Don't know what they're all using them for yet. So when you look at this space, obviously there aren't long studies with data to collect. And we look at investing, and kind of great example that Greg just gave, you don't quite know, but there's a need and a gap. How do you start building that out? How do you begin to inform in the work that you would look at?
Yeah, well, so we recently put together what we called an AI task force, which was a dozen health systems who had been early adopters of ambient scribe technology. And then we also brought all of the leaders in the ambient scribe technology companies together. And we said, okay, this, in my view, I think this is going to be one of the fastest technology adoptions we've ever seen in healthcare. The pace at which we're going from sort of pilots to full rollout in many of these systems is very fast. And it's a testament to the quality of the experience of that solution, right? It solves a clear need. We've got high documentation burden. Doctors are burned out, and these solutions work very well. But as we sort of rush in response to a great experience, we're trying to get people to sort of pause and say, okay, what do we hope to accomplish? Are we trying to make our doctors more efficient? Are we trying, which people talk about the time saved? Are we trying to remove burnout, right? And get people to stay in the workforce longer? Are we trying to improve patient experience? We want our doctors to turn around and face their patients. And you can say, yes, we would like all of those things. But unless you begin to really specifically say, what's our purchasing thesis? And then what is the data that we're going to sort of monitor and collect to see if we're accomplishing our goals? You're not going to be able to answer that as a health system. And so far, the health systems are eagerly expanding without always having done those tests. So it was very helpful. I mean, we got CEOs and CFOs of the hospitals, and they said, here's what we're seeing. Is anybody else seeing this? Right? Here's the specialists that are struggling. How do we solve it for that group? And then they said back to the companies, here are the metrics that we would care about. As we expand adoption, these are the metrics that we would like to see, so we know how this is performing in our system and how we want to value this technology. And in fact, in that case, they had a very willing partner on the other side. The solution developers are equally trying to understand what data can we bring forward to demonstrate our value proposition. And it's important because while scribe technology is spreading quickly and perhaps going to commoditize quickly, once you have a company in your EMR doing all of your capture of all of your visits, you start to see other obvious applications around revenue cycle management, coding and billing, staffing. And so you want to be thinking very carefully about which of those partners you're choosing and how you're rolling that solution out.
Yeah, I mean, I think it's if at the beginning you were going to invest, how do you have the right metrics to know what success, particularly in improving health value, would be? How will it help you? Who are the different stakeholders? And then how can you be transparent with it? And you'll hear us say this at the Capital Impact Council, that transparency of learning and then making it available to larger audiences is really a big part of the work that we're focused on. Lisa, the American Heart Association has done a lot of research in basic science, and though she's not in the room, everyone know Nancy Brown is the original of really getting just this type of work done. American Heart Association decided to do venture funding after looking at the science, and then you working with us in the Capital Impact Council, frankly, using, I think, what the American Heart Association is good at. What was the impetus for saying we not only fund basic science, but now we're looking at investing and looking at what's needed there, or what drove the team to that?
Sure. So a lot of people don't realize this, but the first American Heart Association Venture Fund started 9 years ago. And I actually helped start that as a consultant to them. And the whole idea behind it was a conversation. It started with a conversation I had with Nancy, actually. She and I were on a board together, and I said to her, I think it's amazing all the research that's funded, both basic and translational, but how do you know it's making a difference if it never gets to products or services that are actually used day to day in the healthcare system? There's that last mile problem, right? And she said, we should think about that. And I think venture capital in a way is that avenue to bring the whole thing all the way to the end, you know, to where the rubber hits the road, to make sure that all of that good science, all of that good clinical know-how matches up with entrepreneurs that are interested in bringing those things to life for actual people, not just in papers. So that was the beginning of it 9 years ago. We've since added 3 other funds that we're working on. It's great. It's not exactly original. Most of the big not-for-profit associations like Cancer Society, Diabetes, et cetera, do also have venture funds. Because all of us are trying to ensure that good science, good medicine, good clinical know-how makes our mission real. And our mission is to bring health and hope to everyone, everywhere, which is, you know, just a small goal. But I think you have to have that light in front of you that you're heading towards as you think about these investments. And we take that very seriously.
Yeah. You know, I've mentioned this capital impact counts, health value, ROI. I'd encourage all of you to go to the Duke-Margolis site that has the information about all of our members, because there are case studies in the ways that Lisa just talked about, what the American Heart Association is doing, what Greg's talked about, but what all of our members are doing, which is how do we make sure that we have an evaluation, validation process in making sure we're improving health value outcomes? How are we sharing that transparently? How do we broaden that to a larger audience so that when Caroline's looking at evaluations of companies, the investors who invested know, here's what you should do to improve health outcomes, and frankly, not trying to do it all by ourselves, really looking at partnerships. Heard a lot today about technology and how we'll use tools. We hope to influence that as we continue to ensure not just the communications that we're talking about today, but that we're measuring the right things and that we're looking at it in ways and frankly, building upon it. Caroline mentioned a really important thing, how much faster we're getting at this. The more data that we have, the faster you would think we should be able to do some of these evaluations and share back with everyone. I'd ask each of you to give one last comment. If you were looking, based at what Mehmet talked about today, about how they are opening up the marketplace for tools, the link to management of chronic conditions, and how do you ensure that consumers know, feel, understand where we're going and what we're doing. I'd ask you to just comment on how does that hit your work for what you're doing for the next, I don't know, I'd say next annual strategic plan, but let's just say next.
Well, technology has a key role in aligning stakeholders because information helps align disparate parties. We just invested in a company, I won't mention its name, that is trying to do something along these lines and maybe could be relevant for some of the upcoming opportunity sets. If you could take the patient record, best clinical guidelines, and then policy, and put them all in one place, and then have technology sort of figure out what's the recommended next step for a patient that aligns clinical data, the patient record, guidelines and policy, and then put that in front of the patient, the provider, and the payer all at the same time. You could now craft a healthcare journey. You could discuss and debate that journey, knowing that it would or wouldn't get paid for in advance, and pull at it and see, should there be an exception to this rule? Is this aligned with best clinical evidence? So the opportunity really is there to get the right information to the right party, stakeholder at the right time. And I think that's what this initiative hopefully can represent.
Caroline?
I would just urge us to be really clear when we think about technology and how it's plugging into our healthcare system about what we think it's going to accomplish. Sometimes we talk about technology as like magic pixie dust. You sprinkle it and things will get better.
If you build it, they will come.
And I encourage people, I often say to companies, what's your active ingredient? you do lots of important things to engage people, to build a good user experience, but what do you think you are doing that is changing somebody's health outcome? And if you don't know what that is, as you scale, right, you can't continue to expand that impact. And there are patterns. So, where we see the most success across all of our reports are where we have care models or treatment approaches that we know are effective, but that too few people receive. And when you can use technology to make things more convenient, more accessible, and more high fidelity at scale, that's what works. And so just be clear-eyed about that.
Lisa?
I would say that similarly, I think technology is an important tool, obviously, but devoid of services, it doesn't get you very far. I think they need to be together. And I think about things like AI, which we've not invested much in, but the kinds of things we want to use there or find there are things that bring connectivity across the healthcare system. Patients don't really want to think about their health every day. That is kind of a bummer. If you're thinking about your health, it's probably because you don't feel good. So if we have a patient who is coming in for their annual mammogram and they think they're fine, and hopefully they are, but we can use technology to look at that mammogram and say that person actually has heart disease, microvascular disease that is undiagnosed, that you can see through the mammogram, but they don't know that and they're not thinking about that, but they should. We need to make sure they get seen by a cardiologist and get a statin or whatever it may be that they need. We need to make that connection between the technology and the service. We need to make that connection across different service lines. We need to make sure that is meaningful and not terrifying for that patient, and the loop is closed. And they certainly can't do their home breast biopsy. You got to get a service for that. So I think we have to think about it more holistically. Data certainly adds value to the system or has the propensity to add value. But if you don't have the closed loop with the service side, and it doesn't make a difference.
You're here. I want to thank our speakers, Greg, Caroline, Lisa. Thank the Margolis Institute for really bringing together the Capital Impact Council, and look for you guys to hear more from us as we continue our work. Thank you, everyone.
Thanks, Chair.
All right. Thank you all for staying with us. We are the last panel of the day. I am extremely excited about this particular panel. For those of you who do not know me, I'm Christina Socox. I'm the Research Director for Digital Health here at the Duke-Margolis Institute. And I think this panel is going to be incredibly interesting, as I think has already been mentioned, very relevant, as well as we had an RFI drop this morning that is right on a lot of these topics, which is really this being a moment where AI and digital health can really reshape how care is delivered and experienced, making healthcare less burdensome, more accessible, less costly. But that transformation is really only available, it's only possible when we have the right data, the right connections between those data, and the right building blocks to bring it together securely and reliably. And most importantly, the right incentives for the beneficiaries, for the health tech enablers, for the clinicians, for the health plans to actually drive these changes. When we think about some of the major policy announcements that have been made, they're really around this idea of practical alignment between private sector innovators and also the operators and government in order to make this happen. And when we make it happen, we mean practical, meaningful change. So this session is really about how to make real progress in this space in areas that truly matter for both Medicaid and Medicare beneficiaries, but really everyone in the country in order to get more affordable healthcare and better health, particularly through prevention and treating of chronic disease. So I want to introduce my panel. I'm going from this direction. We have Arta Kara, the inaugural Senior Health Advisor for Technology for the CMS Administrator. We have David Chen, who is the co-founder and Chief Strategy Officer at Nuna, which is a company that works to make high-quality healthcare affordable and accessible through data and consumer solutions that focuses on outcomes. And we have Andy Slavic, the founder and board chair emeritus of the United States of Care, a nonprofit organization working to create a system where everyone has access to quality, affordable healthcare. So thank you all for joining us. We've talked a lot today over the last several hours about a lot of the big health goals, both for the country and how CMS is thinking about that and how tech itself can enable that progress. And so I really want to just start out by just asking y'all, where do you see the best opportunities for this progress?
I'll take a start. So I come from a culture where you rather show, not tell. Today is going to be a lot of talking about high-level problems, but I think that's the stage that we're in right now, and I think that's important to sort of be on the same page on first. So I would take a step back and kind of set the stage on why we're doing what we're doing. The North Star is really health. And when I say health, health is cost saving, health is quality of life, health is productivity of the workforce, health is also national security. So, and at this point in time, to really think about health is really kind of multiple factors coming together, I would say. There is this sort of long needed recognition of chronic disease as the primary driver of the vast majority of our costs. How much of our acute needs is really, downstream chronic mismanaged chronic conditions. Sort of the fact that we have this scarcity of professional capacity in our system, and how maybe the ideal kind of care that you would need to target those upstream conditions with more longitudinal lifestyle interventions is really not the kind of care that you could maybe get with the minutes that you have with your physician in the office. And the fact that the reality that our industry is probably the largest industry with, or the most significant at least, the net negative productivity growth over time. So our productivity is going down, and so much of that is due to our rate of adoption of technology compared to other industries. So I think a broader goal that I would want to sort of work with is how might we prove the viability of a new modality of care that's helps bring providers better technology to bear, to really give the kind of tactical support that beneficiaries and then patients more broadly might benefit from on a daily basis, to really target these root causes rather than the symptoms.
Yeah, first of all, thank you all for having me here. I'd like to follow up on what Arta said, right? I think now is a moment in time. I think Dr. Oz, Abe have all said that this is a moment in time where there's a lot of things happening in both technology, but also policy that can enable change and new models of care, especially for the consumer. And when I think about this, it's really from the data technology AI lens, bringing the data technology people really on par with policy. So when I think about this problem, right, you have to kind of look in the past to where we need to go into the future. So in the past, data and technology has always kind of been second fiddle to policy. They've been fairly disconnected when a lot of great ideas in policy has really caused tremendous headache in the industry when it comes to kind of getting the data, building the technology, all of this stuff to support kind of some of these policy initiatives. What I find tremendously great in this administration is that they're bringing that conversation up front, right? Dr. Oz is saying, let us go and build products that manage consumer incentivization, or Abe was saying consumer incentivization. We're talking about things like nutrition. These are all fantastic things that we should all be focused on. And the question then becomes, well, how do we get this data to where it needs to be to actually do anything with it? right? But at least we're having this conversation now so that we can actually plan for this with CMS so that we can not waste time, not waste money, and at the end of the day, so that we can actually affect people's lives much more quickly with great ideas that are backed by technology and now artificial intelligence.
You know, a few months ago, Dr. Oz asked me the question, you know, if when you were CMS administrator, if you could have rolled out AI tools to all the Medicaid beneficiaries, what would you have done? And I was like, man, we were just rolling out electronic health records. And like people didn't have computers in their offices. So to some extent, and he talks about this as sort of like in this job, in this role that Arda's in and Mehmet's in, you know, it's sort of like building a pyramid. You know, you've got to build it over generations of people and leadership. And now we've got some basic infrastructure in place. My response was, you know, if I had an opportunity to individually meet the needs, or said another way, give an agent or whatever the language of today, an avatar to these people in the program that could help them make their decisions to stay healthier, I'd absolutely do it. But that requires you to think about CMS differently. Someone asked the question in an earlier panel, you know, what are the levers, what are the policy levers CMS has to implement kind of evidence-based prevention? And there are levers, but if you think about the CMS organization as regulators, but don't just think about them as regulators. Think about them as the accountable body to provide care and services to 130, 140, 150 million people, most of them who live on a fixed income or a low income and are incredibly challenged just to basically get their basic healthcare needs met. And if you think about them that way, as that accountable party, they're operators, they're technologists, they're people, they've got lots of levers. And, you know, bringing in someone like Arda to, you know, provide a technology vision, I think is an incredible first step. But we can now start to look at people and say, evidence-based prevention, if that's the theme that you're hearing today, can we give people the technology now to do that? And I think it's as simple as that.
So I think that, you know, we've already actually talked a little bit, I've started the conversation about this, but I do want to talk about it a little bit more explicitly. I think I already know what Art is going to say. But I think that one of the things that looking at the landscape that I have questions around is what is the vision for where we're going to end up when we think about that tech-enabled care? Is it really just today's environment, but with robot assistance? Or is it really opening up new possibilities around moving care to the home, around having more of an emphasis on prevention and better symptom management? You know, is it a combination of the two? And do we have any kind of leading use cases to think about how that care could look different?
I'll maybe start with what, you know, going off of what Andy was saying. Let's, you know, think about where we are today. So, you know, if a patient wanted to put together their health records, this is data that they have a right to, that they should have access to. If you use some of the best in the business, you know, the best tools to do this, you'll have to remember every provider that you've been to, have had created credentials with each of them. As a senior, like most Medicare beneficiaries are, you have to remember the credentials, put them in, have them expire on you at different intervals. If you get through that whack-a-mole, then you get to mostly just stare at your records. And that's what you get on the other end. You know, even for someone who's, you know, excited, optimistic, passionate about health, and it's different than healthcare and technology, I don't know if I have that many apps available to me that really know me or know my risks and my needs beyond what I typed in on that day when I installed the app. And that seems not right. That seems like a unacceptable state of things in 2025 with every other industry where they are. So, you know, how do we have to just get from here to there, and we can sort of talk about where there is afterwards, but I'll pause there for them.
Yeah, I think to add on to that, I think with this democratization of data, pulling it together, enabling technologies, I think you actually change healthcare fundamentally, right? Because healthcare is no longer really, at the physician's office. Healthcare should be really about caring for your health and all of the time between your physician visits, right? That's when people start needing to actually manage their own health, whether they're on medication and they have to be responsible for taking their medication, whether they should be on a good diet. All of these things that are in the MAHA kind of philosophy are there's no argument there, right? We need to do that. Now the question is, how do you get there and how do you build the right incentives to support that in a world that's always been basically paying for volume, paying for more health care in the office. I think with how Abe and Dr. Oz are thinking about kind of the new incentive models, that will support kind of the creation of the environment by which these applications can flourish. And then when you bring in the word evidence-based, now you're asking these applications to give you information so that you can make sure that they're doing what they're doing, what they're supposed to be doing, and generating an ROI, right? So there's a entire loop here that needs much more kind of thought. But I do think that if this were done, it would change how we view healthcare, and we would move. And to Otter's earlier point, the care from a population that is sadly shrinking, right? There's not as many primary care providers in the world, downstream to nurses, downstream to community health workers, downstream to your family members, your social network, your churches. So I think a lot of how we think about how we sustain the healthcare economy in the future needs to envision a world where it's not just at the hospital's office, it's not the responsibility of just the provider, it's everybody's individual responsibility.
I've always thought that when technology is highly visible and talked about, it's failing us. And when technology disappears into the background and we no longer notice it, it's making us more productive and it's helping us. And we're still in that stage in healthcare where healthcare is sucking productivity away from us because we are using technology. We're not doing jobs, we're not accomplishing tasks, we're not getting where we want to go. And in fact, the language we use in healthcare, if you think about it, is so counter to what good technologists are trained on. We want to engage people, we want to do this to people, we want to change their behavior. Well, those aren't things that people necessarily are asking for. When technology works for us, it's like ambient technology in the doctor's office is a perfect example. Why should you have to type in your electronic medical record? Why should you have to go back and look up histories? You'll have a record now of your patient visits that'll be accessible to patient and physician in the background while the patient is talking to the doctor. They're actually talking to each other and the technology is happening in the background. And so that's where we have to get to. We have to get to this place where we are actually no longer talking about technology. We're talking about whatever goal we have, productivity, human health, et cetera. And we all know that all those things become possible. If you walk, the source of so much pessimism today in healthcare is because people know that it's not because people don't know the things that they want to do. It's because they know that the things they want to do just aren't really possible, practical to do at any amount of scale. Yeah. So they just don't try, they give up. And that pessimism could very easily change to optimism if you felt like you could actually do the things you knew you wanted to do quite easily. And that's where I think we may be on the cusp of getting to.
Yeah. And actually that leads right into my next question, which is really around the enormous amount of administrative work that really slows things down for patients, but also makes it really difficult to actually implement some of these innovative care value frameworks, some of the preventative frameworks, and things like that. Do y'all have examples of where AI might be able to change some of that?
Yeah, I can tell you an example I just got today from Sandeep from UHC. And I got his permission to talk about this, by the way, just in case. But basically, their UHC app, right? They've trained LLMs on the explanation of benefits and claims so that someone can interact with the bot and figure out kind of how much a potential procedure can cost, right? If you took that away from them, first of all, the patient has no idea what something will cost, right? Which gives the patient anxiety. But then you know, what's the patient going to do? They're probably going to call UHC. UHC's the operator on their side is probably not going to exactly know what to do. It's going to cost a lot of time and energy spent not answering a question, right? So by implementing these new models on a really kind of critical problem about just price transparency and explaining it to the consumer, they're going to shortcut this tremendously and saving time, money, anxiety, and actually giving a good customer experience to the patient, which is a fantastic thing to do with these types of technologies.
Absolutely.
You also, go ahead.
I was just going to say, I think there are two sides to that. So far, so much of our new productivity or utilization of new tools have been in billing or in more supportive workflows. It's maybe where the biggest pull was, or maybe the most alignment was. And so it's we should not give up on that ideal of the learning health networks and the patient-centric set of tools that actually look out for the benefit of the patient just yet. But at the same time, yes, there is a lot of today scheduling an appointment for most people is a long wait on the phone. Getting transparency into prices, there's been good progress. There's some dilution. There's now good progress again. Going to if you get that appointment and can go to the doctor's office, you still have those clipboards, and there's all data that's actually available in the system, just not flowing to the right places. And then the earlier panel talked about this a little bit. When you have a symptom, have a worry, have a lab result that you're worried about, and you're really trying to figure out where to go. We were talking about it with someone, Chris Klomp, earlier today. Just a map does not exist. So for the GPS, the navigator to exist, the map has to exist in the first place. And so, yeah.
So we still need some pieces being built to make everything else happen. Do you want to add anything?
Yeah, you all remember Toyin Ajayi. She was sitting right up here earlier today, the CEO of City Block Health. They're serving the most hard to treat people in the country, dual-eligible people on Medicaid. And they've got to do these sort of 250 question assessments when they onboard people, like by some cases by regulation. And so, you imagine this, like, do you have any medical conditions? Yes. Do you have schizophrenia? Yes. And then go down this decision tree and have this horrible, awkward, stilted conversation where you're asking all these questions. And of course, what does City Block want? City Block wants these people to have human conversations with them and engage them and show empathy. And so now what they do is they have an AI bot that basically does all the form filling. They can have the people who are providing care ask questions in any order they want. And whatever the person says, it will populate the form that needs to be filled out. So they can actually say, oh my God, I'm so sorry to hear that. Are you on any medication? Is it working? Do you have any side effects? How are you feeling? And then the thing just populates itself automatically in whatever order the questions are listed. But they can take the conversation any way they want. And guess what they have? More successful conversations, happier care providers, happier patients. Because the form was put together for a reason. The form was put together because they thought it would be helpful. But the people who put together the form really are crippling us if we let that be our state of the art. And so I think the coolest thing about this AI technology is that type of thing wasn't a top-down new product from some Silicon Valley firm. That was the work of the people who were sitting there doing the surveys saying, hey, could we use the technology this way? Could we use it that way? And the bottom-up inventiveness nature of AI, I think, is where a lot of the promise is.
So I think, and that's actually a fabulous transition to really the next question I have, which is, we've talked about some of the use cases. Now let's look under the hood a little bit. Really, when we talk about AI, it's built on data, it runs on data, it's got to be monitored through data. And we have a new RFI that's really looking at that data infrastructure and asking about what's working, what's not working. And so I'd love to just kind of have y'all talk a little bit about, these visions. Do they require a more cohesive data infrastructure than we currently have? Can we do some of it with what we currently have? If we can't, what does that more infrastructure need to look like, and what's stopping that from happening?
So you mentioned RFI, so that's what we're looking to understand a little bit of. Sort of, there's so much that works on paper, but not in the real world, not in practice. And I think those have been different tracks so far. There's been a sort of a policy track, and as long as the words exist, it probably exists somewhere and works as needed. And then there's a separate sort of set of folks that actually need to think about what the patients have to go through and what sort of tools can help them and what outcomes they actually end up getting. So yes, there is a lot of work, foundational building blocks that might have been built so far, but I think we also have to sort of reckon with what is working now and what's not. And one metaphor that we sometimes use among us is sort of if we think about this as the internet of health, internet was a government product originally, and it's there's probably a set of things that the government and various government agencies are in a unique position to be able to provide. But I think also it feels like we're in the most sort of the AOL, the sort of walled garden era of the internet, where as long as you're within that walled garden, some set of things work, but it's hard to sort of get to that open choice and competition and sort of the novel ideas actually emerging and being iterated on. And so the RFI is one way that we're looking to understand sort of what set of, as they use it at the time, sort of parsimonious set of standards that we can look to establish to sort of get to that free and open internet and what's needed for that.
Yeah, to the point of like data and healthcare data, some truths, healthcare data is really dirty. We've tried this before, right? Meaningful use, data interoperability, TEFCA. There's a bunch of stuff we've tried to try to bring data together. And that's kind of not really been, we've never really achieved the promise of that in what we would hope, right? I think with this new advent of kind of way of thinking about the problem, thinking about this as outcomes, as applications, as things that will use the data and harness it for certain activities, has the ability to kind of focus the question rather than a kind of do everything, pull all data together, it'll solve all problems kind of mentality, right? Because we can say we can pull all the data together, oh, it's going to be a great world, a great outcome after that. But at the end of the day, that problem is a very, very, very hard problem to solve. But if we can focus on what are CMS's priorities, what do we need to solve for the patient? What do we need to solve for the provider and the health plan? We can start thinking about what is the kind of core set of information that we can pull in an ideal manner that's not painful. Because what we've seen in the past with things like Medicare Advantage and submitting quality scores, it can get as painful as humanly possible. So as we focus on kind of the outcome that we're looking for, we can come up with a subset of data that are required to solve that. And my only other comment here is like, don't boil the ocean here, right? Like, let's solve some problems, solve some really, really important problems, show that it works, and iteratively kind of expand the set of data so that you can solve more problems.
And it sounds like you're saying strategically pick the use cases that might incentivize solving some of the gaps.
Yeah, I mean, I think you sit back and ask yourself, why would CMS send out an RFI on this topic right now? Like, what does that signal? And let me just try to interpret it for you. It means they're prepared to take action. It means that they want to change things. And, I think this is their method, and I think it's the right method, by the way, of saying, all of y'all have so many great ideas. I can't tell you how many times someone comes up and tells me how they can fix this problem, that problem, or the other problem. And so people want to know, well, how do I get people to listen to me? Because I have the best answer, or I have an answer, or I have an opinion. And then these RFIs come out, and then people probably think, well, do people really read that stuff? Does it really matter? Should I spend my time? Does it go into a vacuum? Well, I know these guys are probably going to read every word. Am I right?
Yes, for better or for worse, yeah.
And I'll probably read an AI abstracted version of the responses for my David GPT over here. But I think like there are so many signals in this RFI, and I would encourage you, if you care at all about and are either as a user, student, proprietor of any part of the healthcare system that relies on technology or data, I would encourage you to look at this and respond to it if you are so moved. That they are going to try to break through. And I see a fair amount of people say, well, but what about Epic? Well, but what about this? Well, but what about that? Nobody says, well, is this technically possible? Of course it's technically possible. It's obviously technically possible. So what they're really asking is, how do we break through those remaining barriers that helps us get this done? And how do we galvanize people to do it? So I think it means that they're about to change something. You can't say you weren't warned, that you didn't have an opportunity to make your voice heard here. And I think we'll be doing a lot of follow-up to make sure that people who do contribute ideas to this, we get you engaged, they get you engaged, and we actually get something done. And I think if I heard Mehmet say it earlier, judge me on this. I think I heard I not put words in his mouth. Chris, Abe, put out an RFI like this. You're basically you're putting it out there in public and saying, help us do something about this.
Yeah. One of the, and I'm just going to pick up a couple of comments. We talked about learning healthcare systems. We talked about the data being messy right now. And we heard from Carolyn in the last session, really talking about making sure that you have the metrics to be able to measure whether you are achieving your goals. And we think about some of the goals that were talked about by Dr. Oz earlier this afternoon, which was around, again, prevention, chronic disease management. So when we think about that data that you need to actually be able to do those sort of things, a lot of that is in that messy data. So are there policy incentives that we can think about that would help improve that data, but also, and I'm the last person to say that AI is going to solve all our problems, but is there some options for AI to actually help out a little bit in helping make this data a little bit more usable? And we talked about ambient scribes, for example. That is collecting data right at point of capture. Is there some potentially some ways that that's going to potentially help the situation?
So this is a thing we're still learning about, obviously, but one comment I'll make there maybe is it shouldn't be a mandate that forces us to do the things that lead to the things that we want to target. It should be everyone acting in the game should be set so that everyone acting in their self-interest actually ends up with the right thing happening in the end, right? So we need every stakeholder in that overall picture. But it's just that I think we need a level playing field for these useful patterns of usage to emerge from that. And like I said, this shouldn't be a science project or just a policy in isolation project. I think it's going to be important to sort of the way we think about this is Andy touched on this a little bit, and I think it resonates with me. You have the patients, the beneficiaries, let's say Medicare, and then on the other hand, you have a set of tools, products, digital health products that either exist today, maybe not directly targeting the needs of Medicare community beneficiaries, or maybe don't exist yet. And and then in between, there are a set of building blocks, connective tissues that need to exist for that interchange to happen in a valuable way. So on one hand, how much of the sort of the community, the beneficiaries, is there even a digital touch point with is something important to understand. And I also agree with what Andy said about sort of it can't be forced engagement. It has to be just blend in the background as just being something useful that you rely on and is valuable to you. On the other hand, how legible can we make the value of solving an important problem for, let's say, Medicare beneficiaries, so that companies could be built and these could be prioritized as important workflows and business cases. And in between is all the the complicated stuff that hopefully is exciting to folks like me to think about of what are the sort of key building blocks needed to be in place. Data is obviously a big one, so there needs to be reliable sort of depth, breadth, timeliness of data, but there also needs to be other things in there like identity, and there needs to be a map of things that you can rely on in the whole system, and a number of things like that. So. And so, if the goal is, and within a very sort of short time frames, because you can't boil the ocean in one go, sort of prove out one slice of this end-to-end change, just so we can get that flywheel going, just so you can close that loop and show, prove the viability of this. I think that will hopefully sort of put us on the right path of history, is my hope.
Yeah, I just want to echo what Arda said about like setting the playing field, right? Like CMS's power is to set the playing field so that people will game it however they want, and that their incentives should be aligned with, like, as a patient's incentive, right? They should all be aligned. But the most challenging thing is what is that playing field, the shape of that? And I think through the responses to this RFI, I think that hopefully CMS will get a good idea of what's out there. Like, what are people actually doing, right? Because there are lots of products out there that are touching the patient already, right? Getting information about their behavioral state, getting information about their chronic care conditions, the RPM vendors. There's a bunch of data that exists. Now, what of that is actually useful, and what of that is actually aligned to where CMS wants to go? And also, which does CMS want to kind of take further is going to be the question to kind of set that playing field. But a lot of this stuff already exists. This is not an invention of something new, right? This is actually just refocusing, I would say, about how to leverage this in a way that actually helps the patients, not just the system as a whole.
It's a really interesting question that I hope we turn to, which is, what is it going to take to be successful at this, at using AI, using tech, using data? Who are going to be the most successful people? What will they compete on? What will characterize them? And it's an exciting question, because I think it won't have to be, I got to get really good at working with messy data. If that's what you have to get really good at, you're getting distracted, sadly. So, I think there's three things that, Town Hall Ventures, my team, were writing a paper on the modern tech stack, and what are the criteria to win with the modern tech stack. And, I think it's, number one, just a massive amount of kind of curiosity and experimentation. This can happen now at the level of people who use the technology, not the technology team. And if you can instill if this feels like a technology project or implementation, it won't get to its maximum effect. And I think, our kids are probably really, really good at AI queries. It'll probably be a major very soon at most universities, and like being good at querying intelligently. That has to permeate organizations. The second thing I think is patient intimacy. If we don't have a culture of building that understanding of what people really want and what they really do, then the technology doesn't matter. But once we do, I think we do change workflows. I don't think we just automate the way things work. I think we automate around people. And the third is an infrastructure that's private, secure, and has proper data governance. So I'm not going to say, you can't sit here and say the data doesn't matter. You have to say, somebody has to be in the back room saying, this is what, that part of the organ is called. And if someone refers to it, it means the same thing as when someone refers to some other word. Like, there has to be that level of governance, or the computer's going to give you bad answers. And then this has to be done in secure, private ways. Every doctor, I'm sure, could just get on ChatGPT and throw my whole electronic medical record on and ask for help. But that's not proper, right? But there are environments. Qualified health is an environment that people are putting in place. That's a private, secure environment that people can do all the querying they want and have to worry about privacy and security. It's already out there. So, I think these kinds of things in place, and all of a sudden, I think people can run faster.
So we only have 3 minutes left. This is going to be a little bit of a lightning round, but I think this has been a fabulous session. As all of y'all have noted, and again, Dr. Oz said this morning, this is really meant to be a public-private collaboration where both sides need to work together to make this happen. So how can CMS and private partners best work together on this? Are there examples that already exist that we can expand? Are there new initiatives? How do we start making that flywheel that Arda talked about? I'm going to give Arda a break from starting. I'm going to start actually back with Andy.
You gave me very little time to start with that.
Oh, sorry.
After all the transition handouts I gave you.
It's really about, how do we make that partnership that you were talking about?
Yeah. Look, I mean, as someone who's been in government and in the private sector, I can tell you, you're looking at the same problem using very different language and very isolated to people who are on the other side of this. Just know that people inside government really, really, really care what you think. They really, really care what people who are actually seeing patients, practicing care, working in community health centers want, what they think, what they do. They're asking for this as part of the RFI. I don't think it could be any plainer. I watched Abe stand outside earlier today and talk to literally everybody that came up to him and engage with all of them, all their ideas, all their questions, et cetera. I think, one of the reasons Dr. Oz is a good communicator is not just because he's a good talker, he's actually quite a good listener. And I think that's going to permeate CMS.
So I have a few different tips or requests. So when we were doing government work, right, procurement is a pain. And getting involved with CMS or any federal organization as a kind of a startup is very difficult just because of just how procurement runs, right? So having contract vehicles that are much more feasible for startups would be great. Being open to companies in the private world, viewing this as a pilot, right? Like in the private world, like you can go work with a health provider system or a health plan and say, we're going to do a pilot on this population. I think CMMI would be a great kind of organization, if it's statutorily acceptable, to run these pilot with these kind of private companies as part of that. I think just really bringing it to Andy's point, right? Just bringing in ideas to CMS. Like when we were talking to CMS, they've never had a problem with hearing our ideas, right? Some of them are like, no, we have this other concept, fine, great. But the ideas that are never just like thrown away and said, we know better than you. So really encouraging that kind of conversation between private market vendors, services with CMS, and that open door policy, I think will go a long way.
And I'll give you the last word.
Just only 30 seconds, so I'll keep it quick. But I think the important thing is that the recognition that there's a set of things that government is a unique position to establish and put out, and there's a set of things that the innovators and various private entities competing with each other will create the most creative, valuable, thoughtful solutions for the most novel problems. And I think finding where that line is and setting the right rules for that ecosystem to flourish is what's top of mind. Yeah.
Well, thank you so much. I really appreciate y'all coming up and giving us your thoughts on these topics.
Thank you so much.
Thanks, Arda. Thanks, Christina. All right, I know people are packing up their bags. It's almost time to go. And so you got to listen to Mark, 10 minutes summarizing what went on today. Don't worry, there was so much packed in today. I'm not going to try to summarize. I just want to thank the people who made this event and everything that went into it possible. We started out the day hearing from Dr. Oz, talking about how this is a historic moment. We ended the day with our last panel on technology and enablement, talking about how this is a historic moment. Governor Moore, in between, same thing. American voters, last November. This is a historic moment where change is happening. And I go back to another thing that Mehmet said earlier was, waste a crisis. There was also something in there about when you're in the middle of a code, don't call the intellectual. But I gotta say, after hearing from all of the different perspectives that came together today, it really does take a range of perspectives, not just to talk about, as I think Art on our last panel was saying, this is not just an intellectual exercise or a science project or something that's happening in theory. This is people's lives that are literally at stake with the kinds of decisions that come out and hopefully are influenced by gatherings and events like this one. At Duke-Margolis, what we really try to do is bring together different perspectives, not just on the surface and not just have a conversation, but to find a way to merge things like science and evidence. You heard the theme from Dr. Oz, Abe earlier today too. Evidence-based prevention with a pathway to implementation. How do we actually get this done? And so I'd like to just, if you bear with me, a few perspectives for thanks that made today possible. It starts with the speakers and moderators who contributed to the sessions. Thanks to all of them. I don't think when we do these events, it's not just a matter, getting up on stage and having a conversation. Like Cheryl Pigas, who helped lead the discussion about what's the future of private investment in healthcare, something we really need, something there were a whole lot of concerns about, are we doing it effectively? She has been working with me and with us at Duke-Margolis for months to try to get from just stating a problem and thinking about it as an intellectual exercise to something that can actually be solved. Andy Slavitt from Town Hall Ventures, who's on the last panel, has been a terrific partner for years working with Duke-Margolis, but especially now in this historic moment where we're going to be doing more together, building on the kinds of ideas here. By the way, I got to do a little Duke-Margolis advertisement. Next Monday, thanks to the West Foundation, we're having a CMMI strategy webinar that Andy and others you've seen today, as well as a range of other perspectives, will be participating in. Part of CMMI's efforts to really try to engage with not just us and not just people in this room or with us online, but so many different perspectives. I like that image of Abe outside the room. By the way, Kate Davidson, a career staff member committed to the Innovation Center's goals, and right next to him, talking to everyone who wants to listen. I think hopefully they'll still be with us for a beer after this too. So it's those kinds of deeper partnerships that we really try to bring forward. Also helping us make all this happen have been our sponsors for events like this one and for our ongoing efforts. These are not short-term partnerships, they're ongoing collaborations and support. Alexandria Summit, Lynn Zadowski, the Robertson Foundation, the Collective to Strengthen Pathways for Health Research. You heard about that ongoing philanthropic effort to meet the moment. The Peterson Center on Healthcare and its support for generating that timely and relevant evidence. West Health, Tim Lash, Shelley Leifert, who've been thought partners for the long term as we've developed and grown the Margolis Institute, USP, ongoing challenges around drug supplies and the like. So these are ongoing partnerships, and those partnerships extend as well to the federal government workers. Particularly today, we've highlighted a lot of CMS issues, and that includes a lot of the CMS new leaders who are taking on some big challenges and doing it with a level of seriousness and humility that gives them, I think, the best chance for success. And also special thanks to the CMS career staff who have been part of this effort and helped us put this event and activities together. Their time is so valuable and we really appreciate them spending it with us. And I want to just add too, we've had a lot of our other federal healthcare partners with us today and in the prep for this meeting. This is a special round of applause to our federal employees who are with us today and making this possible. It's so important, as Dr. Oz said at the beginning. Last, a big and special thanks to the Duke-Margolis team who helped make this possible. If you'll bear with me just for a moment, we had a lot of staff who've been working with us on an ongoing basis to get this together. Luke DeRocher, Hannah Vitello, Sevi Bhushan, Christina Silcox, you just saw on stage, Stephen Colville, Lauren McCrary, Frank McStay, Val Lehman, Rebecca Whitaker, Montgomery Smith, Bonnie Smith, Hillary Campbell, Katie Armstrong and Audrey Ford, our lean and mean CIC team, and Martha Ricard, who I wouldn't even know where to go if it weren't for her, our executive team, Jillian Schmidler, Gabe Albers, Patty Green, a lot of time in the communications and organization to get this together, Marianne Hamilton Lopez, Amanda McBroom, and Rob Saunders. And then finally, all of the rest of the Duke-Margolis team. You'll see them if you stay for those of you who are here, if you stay for the reception, most of them have their name tags on. Go up and talk to them. They really do want to hear from you. And I promise, whatever you tell them, feedback on this event, what we could do better, what we could do different, who we should be talking to and whose perspectives we should be taking into account that we aren't already, they will take that back and put it into the process for where we go from here on this journey together. Because we're only going to get there by finding ways to work together and bring all of these perspectives, all of these insights into changes, healthcare reforms that really make a difference for people. For those of you who are with us online, thanks for staying with us all afternoon. I wish I could give you all a free beer too, but for those of you who are in the room, please do stick around and continue this conversation. We are not done yet. I think Arta said it. We're at a stage where we're still doing a fair amount of talking, but there is a lot of action taking place, and we are going to make the most together, I hope, on transforming the care and meeting the historic moment that seems possible today. But as Governor Moore said, look, this is hard work. It's not going to be easy, but let's do it together. Thank you all so much for being with us on this journey.